all enjoyed your lunch? Yes or no? No, yet half the people are yet having their lunch. Okay, all can. Dessert, okay, dessert. I hope you enjoyed your lunch, now enjoying your dessert. So, as we continue with the sessions, let us carry forward the spirit of learning, sharing, and growing together. Because at the end of the day, medicine is not just a profession, it is a commitment to humanity. Now, inviting Dr. Sulkashama Yadav and Dr. Sushil Hulavli to introduce our next speaker for the session. Inviting Dr. Ajit Morankar and Dr. Kumar Dore to introduce our speaker for this session. Let's give them a big round of applause.
I hope everyone enjoyed their meal and everyone is back now. It gives me immense pleasure to welcome our next speaker, Dr. Karan Anandpura. Dr. Karan Manoj Anandpura is highly skilled vascular and interventional radiologist with approximately 10 years of professional experience. Renowned for his expertise in minimally invasive procedures, Dr. Anandpura specializes in diagnosing and treating a variety of vascular conditions and diseases using advanced imaging techniques.
In his decade-long career, Dr. Anandpara has been dedicated to continuous learning and staying abreast of the latest advancements in vascular and interventional radiology. Dr. Anandpara's commitment to patient-centered care and his meticulous approach to treatment have earned him reputation for excellence in his field. His blend of technical skill and compassionate care makes him a trusted and respected figure among his peers and patients alike. Now he is attached to the Heart and Vascular Super Specialty Hospital.
So let us all warmly welcome most esteemed and honorable guest, Dr. Karan Anandpara. Sir, please.
Good afternoon, everyone, and thank you for this opportunity to come and share whatever we are doing in our center at Heart and Vascular Super Specialty Hospitals, Ghatkopar. So I'm an interventional radiologist dealing with the entire spectrum of IR, right from varicose veins to deep vein thrombosis to pulmonary embolism, including the latest advances as well, like prostate artery embolizations, uterine fibroid embolizations. For today's talk, I have chosen a topic which is very, very relevant in today's time, and that is diabetic foot. Now, we all know that, one second, I'll just load that, yeah. Is it loaded? Yeah. Okay. So, I'm going to be talking about diabetic foot. Now, this is a very, very relevant topic. 1 in 10 diabetics have some sort of peripheral vascular disease. And by that I mean that secondary to diabetes, blood flow to the legs is reduced, and that is causing symptoms in these patients. At our center, we are running a dedicated diabetic foot program. This lecture is going to be purely interactive, just case-based discussions. मेरे पास कुछ 6-7 cases है. I'm going to show that over the span of the next 20-25 minutes, and then we can just discuss as to how we are managing, when to refer the patient, when not to refer the patient, and what are the medication that we are using for these patients. So starting off with case 1. Now this was a 62-year-old male, chronic smoker था, diabetic, hypertensive, good performance status. Patient आया था OPD में, he said he can walk for 30 minutes. 30 minutes के बाद he said he started having cramping pain in both lower limbs, classical for something called as claudication. Now this is a classical history of claudication. How would you proceed with this? So I think the first step is to take a detailed history. History में आपको क्या पूछना है? How is the kind of pain? Pain in claudications is classically cramping in nature. It typically lasts for 5 to 10 minutes. It would start around 5 to 10 minutes after starting, and the moment the patient rests, patient बैठ जाता है, patient बोलता है मेरा पेन गायब हो जाता है. Classically, this pain would be in the back of the thigh and the buttocks. So this is the first thing that you need to do when the patient comes to you. That is this claudication pain? The second thing you want to do is that you want to rule out mimickers of claudication. कि ये pain किसी और वजह से नहीं है. What do you need to rule out? A, whether this is not lumbar sort of pain, lumbar canal stenosis, or nerve root compression or disc disease, whether this is not hip pain, unilateral pain nahi hai, right or left side, whether it is not in the hips, whether it is not knee pain, which could suggest some sort of degenerative osteoarthritis of the knee, and most likely you need to rule out venous causes. Venous causes you need to rule out कि patient को swelling तो नहीं है, patient does not have superficial varicosities, so you need to rule out all of this. Following this, ideally जो first test आप बताएंगे patient को करने को, that would be a color Doppler. When you ask for a color Doppler, you should be asking, please do color Doppler of both lower limbs to rule out whether the patient has iliac disease, femoral disease, or below knee disease. And then you need to evaluate these patients, and ideally ये patient को either एक CT scan लगेगा या फिर एक MR angiography लगेगा. This is a non-invasive angiography, and what we typically do is we cover right from the infrarenal aorta. You want to rule out कि patient को कोई aorta में तो block नहीं है जिसकी वजह से दोनों पैर में pain है. So whenever you even giving a prescription, you should be writing CT or MR angiography, both lower limbs. Please include the infrarenal aorta right up to the legs. अभी हमने जब CT scan कराया, this was the finding in this patient particularly. Some blockages in the anterior tibial artery. Popliteals तक flow अच्छा आ रहा था. Below the knee, the patient had some blockages in the lower limb arteries below the level of the knee. So to summarize, this was the case. 62-year-old male, कोई gangrene नहीं था. There was no tissue loss, there was no ulcer. Patient was able to walk for 30 minutes, 62-year-old, with some diseases below the knee. How would you proceed? With a show of hands, how many would go ahead and ask कि नहीं आप जाके angiography or angioplasty करा लो ये blockages के लिए? And how many would say कि कुछ नहीं करने की ज़रूरत है? Can we have a show of hands? कितने बोलेंगे कि जाके कुछ करा दीजिए इसके लिए? Okay. So we have some people who would say कि आप कुछ करा दो. Now the data in this is very very clear. जब भी blockages घुटने के नीचे है, by that I mean infrapopliteal blockages, the data is कुछ नहीं करना है. Just conservative management. And by conservative management, I don't mean कि patient को बताना है कि you don't have to do anything after this. The patient needs to be managed with antiplatelets, and rather than keeping these patients just on ecospirin or DAPT, we generally keep these patients on low dose aspirin, which is aspirin ecospirin 75, and we've started adding antithrombotic doses, NOAC. So we generally add Xarelto or rivaroxaban 2.5 BD, and then we add vasodilators. So Complamina 150 BD, Trental TDS, and Stilose, Silestazole 50 BD is what we would add. These are vasodilators you add to improve the blood flow. But इतने छोटे blockages के लिए there is no need to go for an angiography or an angioplasty. Why? Because the patient is only claudicant. The patient does not have any gangrene. So the rule is clear कि अगर non-lifestyle limiting claudication है, patient is able to walk for 30-35 minutes, छोटे मोटे blockages है, that also blockages below the level of the knee, nothing needs to be done. These patients only need to be managed with medication. But one important thing you need to tell them, and that is foot care. By diabetic foot care, I mean that इनको कोई जख्म या ulcer बनना नहीं चाहिए. The moment that these patients have an ulcer, you are potentially turning these patients into pre-gangrenous stage where they can go for limb loss. So some instructions you need to give these patients. एक extreme hot water or extreme cold water say they should not be washing their legs. Nail cutting. When they are cutting the nails, they should be very careful because they also have diabetic neuropathy. So they will not realize when the nails will get cut and when they will get an ulcer or a wound in the leg. Most importantly, closed shoes at all times. Slippers is not allowed. They need to examine the webs of their spaces whenever they are taking a bath for any fungal infection or small wound. And close shoes at all times, especially when they are going out. घर पे अगर है तो socks at all time. These are basic instructions that you need to give patients who are diabetic, who have peripheral vascular disease and small blockages which need to be managed conservatively. Obviously, after this, lipids, anti-lipids need to be added, and one cardiology consult because 1/3 of patients with peripheral vascular disease will have some blockages in the heart. Just one point I want to touch over here in diabetic foot or in peripheral vascular disease, with ecosprin, we are also adding anticoagulation. And by anticoagulation, I mean rivaroxaban 2.5 mg, which is Xarelto. There is good data. I'm not going to go into the details with this, but there is good data with two studies. One is the COMPASS study, and one is the Voyager PAD study. And both of these studies have shown that when you have two limbs, एक patient में हमने सिर्फ ecosprin रखा, दूसरे limb में हमने patient को ecosprin plus rivaroxaban रखा, limb salvage rates and amputation rates are lower when you're giving combined dosage rather than ecosprin alone. So that was just one point that I wanted to highlight. Take home message with case 1 is that asymptomatic patients without any wound, without tissue loss, with small blockages below the knee, conservative management only. We'll go to the second case. We had a 70-year-old male now. Again, similar history, diabetic, hypertensive, smoker, good performance status. But compared to the first case, this patient can only walk for 5 minutes. The first patient that we saw was able to walk for around 30 to 40 minutes before he started getting cramping pain. In this patient has lifestyle limiting claudication, cannot walk for more than 50 meters. वो बता रहा है मैं यहाँ से I go to the ground floor, my legs start paining. Now this is where we need to intervene. And also these kind of patients will surely have major blockages. अगर major blockages रहते नहीं है, the patient will never have such symptoms. So similarly, we went with a CT angiography, a high level block at the level of the right common iliac artery. So this was a high level block, heavily calcified block. So standard in this is that these patients with iliac blockages or SFA blockages with lifestyle limiting claudication, you go ahead and advise an angiography and an angioplasty or a stenting. So this was a standard procedure. You would go with angiography and angioplasty and stenting, but heavily calcified bar of calcium. Is there something that we can do? Apne, I think majority all of you all must have heard there is IVL which we are doing for the coronaries. We have special IVL balloons जहाँ पे calcium तोड़ते हैं. Similarly, in your urology practice, we must have seen that you are using lithotripsy to burn the to break the calcium stones. We now have peripheral IVL balloons. So similar balloons to the coronary balloons, but this actually breaks the calcium, and it not only breaks the intimal calcium but also the medial calcium in the walls. So if patients are affording, because this treatment is expensive, ideally angiography, angioplasty, iliac stenting is surely required, but you can also advise these patients IVL or intravascular lithotripsy for these balloons. So serial IVL balloons is done, and this is an image where we've done serial IVL balloons. So if you compare the first image with the last image, just with serial IVL balloon, you'll see that that bar of calcium which was seen on the first image has actually been broken because of the IVL balloon. So patency, stent patency जब हम बताते हैं, how long will the stent work? If IVL is done to break the calcium, which is now available for the peripherals as well since the last 2 years, the patency of the stent is more. So in this case, we first did an IVL and then we placed an iliac stent for better patency. Just to summarize claudicants, medical line of management is first. Management depends on whether these patients have iliac disease, SFA disease or below knee disease. Ideally, claudicants with below knee disease only, infrapopliteal disease, which are small blockages, no treatment is required aggressively, only medical line of management. If the patient has iliac disease or femoral disease and lifestyle limiting claudication, by lifestyle limiting claudication I mean patient cannot walk for more than 5 to 10 minutes, these are the patients where we need to be aggressive and go ahead with an endovascular first approach with a peripheral angiography, a peripheral angioplasty, and similarly just like the coronaries, agar lambe blockages hai, long blockages or 100% blockages, then a bypass. Moving on to case 3. A 64-year-old male, we'll now move on from the claudicants, jinko koi tissue loss nahi tha, there was no gangrene, we'll now move on to those patients who actually have a wound. So a 64-year-old male, diabetic, chronic tobacco chewer, right leg cellulitis. He went ahead with direct debridement. So this was after the first debridement. He went to a surgeon, the surgeon went ahead and debrided, the limb became black after this. Infective focus was still persistent, WBC counts rising, he went ahead with the second debridement. This was post the second debridement. With every debridement, the wound is becoming bigger, there is no blood flow, and that is why it is becoming blacker. He went ahead with the third debridement after this, and this is when he was referred for a vascular consult to us. After the third debridement, because the limb had started turning black, he came to us and he was advised directly for a below knee amputation. Is that in diabetics, even with a small wound or even with a small focus of cellulitis, a color Doppler should be done first to make sure that there are no blockages. Ideally, if there are minor blockages, you can go ahead with the debridement first. But just like we do a coronary angiography, at least a check peripheral angiography to make sure that blood wahan tak pahunch raha hai, then go ahead with the debridement. Now in these cases, what we generally do is a TCPO2. We measure the oxygen level at the level of the tissue. Ideally, if it is less than 40, we know that these patients are going to go ahead with an amputation. In this case, the TCPO2 was only 12, which means that there were severe blockages in the leg. We have to go ahead and open those up. So we go ahead with an angio now, and just like an angiography of the heart, we do an angiography of the leg. So this was the angiography. Agar aap dekh rahe ho, whatever in black, that is the blood vessel. So just one blood vessel reaching the foot. The ulcer is the area in red that I have shown. So no blood reaching the ulcer at all. And by now I want to talk something about the angiosome theory. And by angiosome theory is that, I mean that there are three arteries supplying the foot. The anterior tibial artery, the posterior tibial artery, and the peroneal artery. Every part of the foot is supplied by a particular artery. Jahan pe aapka ulcer hai, ideally that artery should be open. In this case, if I go back, the ulcer is in the region of the anterior tibial artery and the anterior tibial artery is closed. That is why the leg has become black. So we need to go ahead and do an anterior tibial artery angioplasty. So agar aap dekhenge, this is post the angioplasty. Earlier there was a single artery. Post the angioplasty, now there are two arteries supplying the leg. So again, pre and the post. Single artery in the first image. After the angioplasty, two good arteries and good flow to the foot. Finally, the ulcer started healing. So he went ahead with 2 weeks post revascularization. He went ahead with HBOT, hyperbaric oxygen and topical oxygen. 4 weeks, this was the ulcer. So after debridement, after revascularization, and after offloading and hyperbaric oxygen, finally this patient had a limb on which he could walk. In fact, this patient was a relative's friend. It took almost 2 months for this ulcer to finally heal after this. So it is a wait and watch policy, but you need to realize that in diabetics, even a small ulcer, Doppler first, followed by revascularization and then a debridement. Case 4, similar history. Again, this was, I think, a 60-year-old female, blackening of the second and third toe. Again, went ahead with a direct debridement, and this was the final X-ray. And the limb had become, again, blackening along the edges of whatever was debridement. So again, the purpose to show this is that it may start off as a small wound or a small area of blackening, but within a few days itself, the moment you debride, because the wound becomes big, the ulcer edges will eventually become black if the patient has a peripheral vascular disease. So again, you go ahead with an angiography. The purpose to show this was multi-level blockages. If you see, there are only collaterals. There is hardly any flow going to the foot. Long blockages in the superficial femoral artery, hardly any flow below the limb. And what you do in this is you open as much as possible. How much ever you can revascularize, it is not possible sometimes to open all the blood vessels, but jitna aap khol sakte ho aur blood flow badha sakte ho, we need to open that up. And you must have heard of angiography and angioplasty done from the groin. In this case, we did something where we did the angioplasty right from the foot, which is called as a retrograde revascularization, which is rare. But we are also doing this at our center. So we take the access below the knee rather than taking the access at the groin. And finally, we did an SFA plasty, a stenting, and this is the blood flow to the foot. Finally, this patient went for an amputation and the wound healed. This was again after 1 to 2 months. The purpose of showing this again is that although we cannot save the entire leg, the patient went for a midfoot amputation with loss of 5 digits, but at least the level of amputation is brought down. Had this patient not gone for a revascularization, the patient would have surely ended with a below knee or an above knee amputation. So revascularization is not only to save the foot, it is also to reduce the level of amputation. So you can convert these patients from a below knee or an above knee amputation to at least a digital or a midfoot amputation. Coming on to case 5. Again, a 65-year-old diabetic, non-healing wound in the region of the heel at this time. Very small. If you look at it, it's a very small wound, conserved. But we did a Doppler first. Low flow in both the anterior tibial artery as well as the posterior tibial artery. And when we did the angiography, in fact, the SFA was also blocked. Again, in this case, you must have heard of drug-eluting stents in the coronaries, which is now a usual. We now have drug-eluting stents even available for the lower limbs. Although they are expensive, but the data also shows that when we are placing a drug-eluting stents in the lower limbs, the patency of these stents is much higher. So again, in this case, we did a SFA plasty, we did an ATA plasty. Now in this case, you need to know, ulcer uska heel region mein hai. We could not open up the artery supplying the blood flow to the heel, but we opened up only the SFA and the anterior tibial artery, जिसको हम बोलते हैं indirect revascularization. Direct blood flow नहीं पहुंचाया है अल्सर को, but indirectly हमने blood flow बढ़ाया है. How do we know कि हमने जितना किया है, whether that is sufficient for wound healing or not? And we now have 2D SmartMap perfusion, and we have this software at our hospital as well in Ghatkopar. This is basically colored images that are provided to us, pre and post images. Pre-plasty, post-plasty. Whatever is green is less blood flow, whatever is towards red, if you look at the charts down also, is more blood flow. So although we have not been able to open up the direct artery supplying blood flow to the heel, by this chart, and by that I mean by this video as well, you're seeing post, how fast the blood is coming down versus pre, how slow the blood is coming. We can give an objective criteria ki haan, even though we've opened up only the femoral artery, the blood flow has definitely improved. More than this, we now get charts. And again, this software is available at our hospital. This is not available at all cath labs as well. It's only available at our hospital and in Bombay, again at Tata and probably at HN, where we get a percentage improvement in the amount of blood flow. So I can confidently tell my surgeon that there is a 213% increase in blood flow just by opening up the femoral artery and the anterior tibial artery. So this criteria, and the purpose of again showing this slide is only to show you that by revascularization, we can now give objective criteria as to the percentage increase in blood flow as well. Coming on to case 6, middle-aged female, 55-year-old, diabetic, single ulcer on the leg, very, very tender, very, very painful, diabetic. Now, one history which is very, very classical in this is that it's a very painful ulcer. Classically, diabetics, because they have diabetic neuropathy, they will never be able to feel the ulcer at all. Most likely, they'll see ulcer ऐसे ही बना, हमें पता भी नहीं चला ulcer कब बना. So when a patient is giving a history that the ulcer is very, very painful and very, very tender, ideally, you need to rule out other causes. And in these cases, sometimes we do a biopsy. And in this case, we did an ulcer edge biopsy because of the history or the clue that the ulcer is painful. And this turned out to be a combined venous ulcer with something called as livedoid vasculopathy. It's a rheumatological condition seen in diabetics where they have small disease vasculitis. So rather than doing an angiography and angioplasty in these patients, what these patients require is just steroids and treatment for the venous cause, compressive therapy. And just with steroids and compressive therapy, this ulcer healed. So the learning point in this is that not all diabetic patients with ulcers are arterial. A detailed history. Sometimes you need to rule out mimickers and rare causes of ulcers which are not healing. By that I mean mixed ulcers, venous ulcers, vasculitis. Or agar koi bhi doubt hai, sometimes an ulcer edge biopsy may be required before you label them as a diabetic foot ulcer. Coming to my last case, 64-year-old, sudden loss of sensation, pain, pallor, pulselessness. जो भी हमने cases इसके पहले देखे, those were all chronic cases. History was since 1 month, 2 months. This is a 3 to 4 day history. Sudden pain, pulselessness, pallor, limb has become completely black. This is called as acute limb ischemia, ALI, sudden loss of blood flow. And we need to know 5 P's of ALI: pain, pallor, paresthesia, pulselessness, and paralysis. If a patient comes with unilateral, any of these, ideally ALI needs to be ruled out, and most likely they will present with paralysis. And the paralysis ke saath jab aate, the first thing is that is this a spinal cause? But which spinal cause you need to rule out whether the limb flow is maintained or not. So typically if the patient says that with paralysis the patient has unilateral severe pain, you need to rule out ALI in these cases. ALI management is slightly different from diabetic foot management. In this cases, they require a good MDT workup. You need to do a CPK levels to know whether the tissue is viable or not. And ideally, we do a CPK MB level as well as lactate levels. If this is very high, there is a 50% chance that even if we open up the blood flow, these patients will go ahead with some sort of amputation. Because if the limb is already dead, even if you revascularize, it cannot be converted back to normal. You also need to rule out thrombotic versus embolic, so a 2D echo, and ideally a CT angio of the entire aorta, right from the heart, right up to the lower limb, ki koi aneurysm to nahi hai, ya the plaque is not coming from above. And in these cases, counseling is key, so ideally a CT is done. If you look at the CT and MR is done, if you look at the DSA, there is a sudden cutoff after the femoral artery. No blood flow going down at all. And in this case, we use something called as a hybrid approach. So one is an open surgical approach. So the first option in this is open surgical embolectomy, where you go ahead and remove the clot as well. Embolectomy is good when there are big clots in the femorals or in the iliacs. For below knee clot, we use a hybrid approach. So the surgeon will go ahead and do an embolectomy, and I, as an interventional radiologist, will also use the endovascular approach and give TPA, tissue lysis from inside, which is called as catheter-directed lysis. So combined open surgical plus endovascular approach or a hybrid approach. I think I'm running out of time. I'll just summarize. Preventing amputation is the main aim of treatment when it comes to diabetic, and if we cannot prevent amputation, at least reducing the level of amputation is the key. Revascularization is key, but ultimately it comes to teamwork. Also, you need to tell the patients that after revascularization, it does not end there. 1 से 2 महीने का post procedure oxygen therapy, offloading, and then hopefully after 2 months after revascularization, the ulcer heals. So it does not end at angiography and angioplasty. India is the diabetic capital. We have a lot of these patients that we see. Ultimately, it comes to teamwork and building a diabetic foot clinic where we can prevent these kind of amputations. I have the last 1 minute, and I just want to briefly talk about our hospital. So basically, we run a dedicated cardiovascular unit. We've got around 25 to 30 beds at all centers. We started with our first center in Dadar, HVS Symbiosis Dadar, where we have a team of a cardiologist as well as a vascular and interventional radiologist. And we are running a dedicated cardiovascular program only. Our entire hospital is to deal with cardiology and vascular work only. In cardiology, our first center was in Dadar, and the second one was in Ghatkopar. We have the third one, which is already functioning in Borivali, and the fourth one in Thane. 25 bedded with a dedicated cath lab where we do everything in cardiology, right from ECG, 2D echo, stress test, to complete complex angiographies, angioplasties, IVIS, IVL, ROTA. Highest number in the last month, second highest numbers of TAVI that we've done in Bombay, combining all the centers. In vascular work, we do everything, right from varicose veins, DVTs, peripheral angiographies, angioplasties, and stroke care. So, and we also have a cardiac OT for a CABG program. So if a patient does require a bypass, then it can be referred for bypass at the same hospital as well, including complex vascular work for lower limbs. So FEMPOP bypass, iliofemoral bypass. 3 centers right now functioning, 4th one in Thane, and the 5th one coming up in Pune as well. So 25 bedded, only cardiovascular unit, dedicated end-to-end, head-to-toe entire spectrum of vascular and cardiology work. Thank you.
Saving limbs, restoring lives. That was powerful. Thank you, Dr. Anand Para, for that enriching session.
Thank you.
Let's give him a big round of applause. Now it's time for our 3 lucky draw winners, requesting our speaker to please felicitate our first lucky draw winner.
Dr. Sanjay Paurkar.
Dr. Sanjay Paurkar. Hi, Andar. 1, 2, 3. Chalo, next. Dr. Shehnaz. Dr. Shehnaz. Yes, congratulations, ma'am.
Congratulations, Dr. Shehnaz. Let's give her a big round of applause.
Vijay sir. Savita ma'am.
Now requesting Savita, Dr. Savita Chauhan, owner of Ruby Hospital, to felicitate our next lucky draw winner. Second.
Dr. Nilima Shettivar.
Congratulations, Dr. Nilima.
Deshmukh sir. Welcome, Dr. Ananya Mukherjee madam.
Now requesting Dr. Vital Deshmukh from Astha Hospital to felicitate our third lucky draw winner.
Dr. Mangesh Jadhav sir. Aras.
Congratulations to all the 3 lucky draw winners.
Yeah, I just want to say this is a app-based weighing machine which we are given from Astha Hospital. So app-based weighing machine gives you not only the weight, but it also tells you about the percentage of visceral fat, the subcutaneous fat, the protein, the bone mass, and the water levels in the body. So it's very important to know how much fat, if the patient is overweight, how much fat is actually deposited inside the abdomen, which is actually much more dangerous than your subcutaneous fat. Then whether your bone mass is adequate, whether your protein is adequate. So if you use it in your clinic, so it will give your patient a more, comprehensive idea about what exactly is not just simple obesity, what the patient needs to tackle. Like a liver fat is much more dangerous than just a subcutaneous fat. So it's a useful thing for all clinics. Okay, thank you.
Thank you so much. Now requesting Dr. Mazid Sheikh
Thank you.
and Dr. Sulakshana Yadav to felicitate our speaker, Dr. Karan Anandpara. Let's give him a big round of applause. Thank you so much. Please pay attention. Delegate gifts will be given at the counter to all the delegates at the end of the program. I repeat, delegate gifts will be given at the end of the program. Now, I would like to invite Dr. Sunny Vaikode and Dr. Anjali Mulke to introduce our next speaker.
बसून राहा, स्टे कनेक्टेड. अजून भरपूर बंपर प्राइज पण बाकी आहेत. अजून डेलिगेट्स गिफ्ट्स बाकी आहेत. सरप्राइजेस बाकी आहेत. बिग वन and more big one. Stay connected.
Good afternoon, everyone. I hope after lunch you all are awake. I'm really feeling happy to introduce such a great personality within us, Dr. Suresh K. Bhagat sir. He is an associate director, urology and kidney transplant. He has done his MBBS, MS general surgery and MCS urology in CMC Vellore. He has done thousands of surgeries in his till life, and then also he has published many original RCT articles in the Journal of Urology and other national and international journals also.
Sir's expertise in endourology, laparoscopic urology, pediatric urology, reconstructive urology, transplant surgery, and uro-oncology. Welcome, sir.
Welcome, sir.
Well, I would like to thank you, VKP GP Association, for this wonderful opportunity. So, today I'll be discussing about the common surgical diseases and its management, common urological conditions. So, as of I can say, GPs are the backbone of the medical practice in all over the world, not only in Mumbai. So, because, see, you go to Western world, first of all, you have to consult GPs. You cannot approach to any specialist. To get a urologist in US, you take 3 months unless until you have a dire emergency. So GPs are the backbone of our society as far as the medical facility is concerned. So GPs plays significant part of the day-to-day general practice, starting from the lower unit tract symptoms to renal colic to hematuria due to any cause, a stone, tumor, tuberculosis. Many of these conditions can be managed initially by conservative management. The GPs play a crucial role in early identification, initial management, and timely referral to urologist. So what are the common urological conditions? I will start from the BPH, that is benign prostatic hyperplasia, then the urolithiasis, renal stone, ureteric stone, bladder stones, and the urinary tract obstruction due to urethral strictures. And of course, the uro-oncology cancers of the kidney, bladder, prostate, urethra, penis, testis, and all. And there's some scrotal conditions like I think it's a critical emergencies, undescended testis with torsion or testicular torsion in a young adolescent boy. Then of course, recurrent UTI may be complicated or simple. So I'll ask you one question. Imagine a 65-year-old gentleman coming to your clinic with worsening urinary symptom, or a young patient is coming with an acute flank pain. What will you do? When will you continue medical management, and when will you refer to urology? So I'll discuss in the forthcoming slides. So 70 to 80% of the BPH can be treated only by medical management, that is alpha blocker or dutasteride or finasteride. When will you refer the patient for surgical management to urologist? Remember, refractory LUTS, refractory lower urinary tract symptoms, is not responding to medical therapy. You must refer. Maybe something wrong. May not be only the prostate, the cause, maybe something else, like, hidden a small bladder tumor, maybe the carcinoma in situ. Then the refractory recurrent retention of urine. Refractory means the patient is on alpha blocker, medical treatment. Then the patient is developing again and urinary retention and requiring catheterization. Number 3, recurrent UTI, bladder stones, hematuria due to prostatic enlargement. Those patients do not respond to medical treatment. Then last not the least is obstructive uropathy with a renal failure. Patient has a BPH and patient has a bilateral hydronephrosis, then the thick bladder wall and the rise in serum creatinine. These are the conditions where you should not wait, refer the patient to urologist. So what are the surgical options for BPH? TURP is still the gold standard. Any new technique always compare their result with the TURP. So TURP can be done up to 70-80 grams of gland, but if the gland size is increased, then the chances of complications like blood loss, TUR syndrome increases. Then the HOLEP, HOLEP is done for the large prostate. Size is not a limit. Then the TUIP, the small gland like transurethral incision of prostate. Then some new technique has come, Eurolift, ITIND, regime, and prostatic artery embolization. So this is I have done a HOLEP in 195 gram prostate. That size is assessed by the transrectal ultrasound, which is the most accurate method of assessing the size. This was a 70-year-old gentleman, diabetic, post-PTCA with ejection fraction of 35%, and he also had thrombocytopenia due to idiopathic hypersplenism. He was suffering from recurrent urinary tract retention with a febrile UTI. So he was on catheter for 2 years. So I decided to do on HOLEP. This you can see this is the laser fiber. You imagine that how HOLEP is done. Imagine an orange. So you are doing HOLEP. So where this fiber goes, what is the plane of enucleation? The peel of the orange and the pulp of the orange. So peel is the prostatic capsule and the pulp is the adenoma, that's the prostatic gland. So you have to go inside between the pulp and peel, between the capsule of the prostate and adenoma. You cannot do HOLEP, you cannot enucleate if you are not in the proper plane. So it requires very high skill. It's a high learning curve, because in TURP you are coming forward, but in the HOLEP you are going backward. You are enucleating the gland from the veru to the bladder neck. So there's a difficult procedure, but it's a very, very safe. In the, you can say the patient is on equospin, you can do HOLEP. No size is the limit. Even I have done the largest gland 260 grams. The enucleation time hardly 2 hours, and then after enucleation you put the gland into the bladder. Then the second instrument is used, that is morcellator. With that morcellator you can nibble the prostate into the small piece, and then you can do the HOLEP. So why HOLEP? HOLEP is a relatively bloodless procedure. If any patient loses 100 ml of blood in the TURP, the in-HOLEP may be hardly 10 ml. So 1/10 of the TURP, the blood loss is there in HOLEP. And it ensures the complete removal of the adenoma, because the enucleation is only possible when you are enucleating between the capsule and the adenoma. And third advantage, normal saline is used, and so normal saline is a physiological isotonic to the blood, so does not cause TUR syndrome as seen in the TURP, because in TURP we use glycine, so that causes the TUR syndrome. So TUR syndrome, bradycardia, hypertension, blurring of vision, these are the dangerous side effect of the TURP due to glycine. Then other thing is the complete adenoma is removed. So reoperation rate is very, very less. Second, the fifth is the bladder neck contraction. Bladder neck contraction does not happen. Okay, it's a bloodless surgery. So so after this removal, this is the morcellator. You see, this is the different instrument, how the enucleated gland is being sucked or morcellated by different machine, and I'll show you how the urine flow at the end. Even the small piece of the gland can be sucked with this morcellator. Now I am drawing the scope. You can see the urethra is pristine, there is no damage. You can see the flow, clear urine, flow is good. So patient can be discharged within 24 to 36 hours. And this is the 150 gram enucleated gland. This is the weight of the enucleated tissue. So why HOLEP I have explained you. Then the second comes the Eurolift. What is Eurolift? The patient selection is very, very important. The a relatively young patient, 50-year-old patient, 60-year-old patient, who wants to preserve their sexual function. They don't want the retrograde ejaculation, because I treat a lot of patients from the Gulf, so they don't want they will not tolerate retrograde ejaculation if you do the TURP. In that situation, Urolift. In this Urolift, so you can see the implant CT, that is the capsular tab made of, this is the nitinol, and then the M is the shaft, that is a PET suture. This is a monofilament suture. U is the urethral tab, that is metallic. So what we do, so you can see here that this is the prostatic enlargement after putting the Urolift, how the prostatic urethral lumen is opened. So patient whites. So it can be done in the daycare. Catheterization is not required. Patient gets relief. But the only 5-year duration is a success. After that, patient requires a reoperation. So this is the ITIND procedure. So this is the temporary implantable nitinol device. So you can see this. This is kept into the, this is placed into the urethra, and after 4, 5, 6 days, it can be removed, and the prostate is reopened. So the prostatic urethral lumen opens. It's also done in daycare. Then the regime. What regime is? Actually, we inject a steam into the prostatic adenoma. So after injecting the steam, that causes the necrosis of the tissue, and that tissue is resolved by the body. So in this also, the sexual function is maintained. There is no retrograde ejaculation. Also, the selection of the patient is important. Only we can do up from 30 grams to 80 grams. No, it should not be done in a smaller gland, less than 30 grams, or not more than 80 grams. Because if you do in a smaller gland, that can cause, steam can cause damage to the surrounding vessels or maybe the rectum also. It should be done very precisely, but only drawback of this procedure that the patient have a lot of symptom after the surgery. It requires catheterization for 5 to 7 days. Suppose according to the 10 gram per day of the catheter duration. If the size of the prostate is 40 grams, then the 4 days catheter. If it is 80 grams, it should be 8 days catheter. But followed by a lot of irritated patient as dysuria, urgency, frequency. So patient will eat our head if you do this surgery. So pre-operative counseling is very, very important. And for the complete success, it takes 3 to 4 weeks. Now I'll come to the stone disease in the urology, urolithiasis, which is the very, very common. So when should we do a intervention in stone disease? I will take a first ureteric stone. Patient presents with ureteric colic, severe ureteric colic, flank pain, vomiting. Okay, so I'll tell you, if the patient is young, not a diabetic, no fever, and there is no significant dilatation of the upper tract, a stone size is up to 6 mm or less than that, so you can start on conservative management with an alpha blocker, that is tamsulosin, silodosin or alfuzosin, which helps in a spontaneous facilitations of the stone. If the patient has persistent pain, the system, that kidney is obstructed. I will show in the next diagram what is if the patient has a perinephric stranding. Remember, perinephric stranding is more serious than the hydronephrosis. If the patient has a perinephric stranding, it means there is a severely obstructed. If the patient count is high, you should not wait. Patient should be treated immediately. In case of fever, high count, perinephric stranding, definitive treatment is not done. Only place a stent to de-obstruct the system. so that the patient should not go into the urosepsis. If the patient has a solitary kidney, no conservative management, must be referred to the urologist in solitary kidney, because patient can have anuria, immediate rise in the creatinine, especially I do transplant. So after donor nephrectomy, patient is advised, if you develop pain or you have feature of a stone, you come immediately to the emergency department. Then the renal stone. So renal stone up to 20 millimeter. Now it is the latest technique, it's not a latest, maybe 15 years old. Retrograde intrarenal surgery can be done, but in the selected patient. I have seen a patient has undergone RIRS, retrograde intrarenal surgery. It is done through the urethra and using a 7 French plastic flexible ureterorenoscope and with the use of laser. The surgery is done, followed by stenting. If a patient, if you put a, you are doing cystoscopy, doing ureteric catheter, and if you see a pus coming from the orifice or infected turbid urine, you should not do, it should be only the stenting. So these are the conditions where the patient should be referred to urologist. Then the PCNL, ESW and URS. So see here, this is a 56-year-old lady. You can see here the small stone, but can you see the kidney? Kidney has got some pus, severe perinephric stenting. Can you see? And see here, this is the perinephric stenting. So the fat is extended due to the lymphatic obstructions. So in this situation, if you see such type of patients, must be referred to the urologist. And now the mini perc. Mini perc is done with the very tiny hole, 16 French in the back, like is not a regular PCNL. In PCNL requires 30 French, but in this 16 French, mini perc can be done, and it can be done without putting a tube on the back side. Okay, so I'll show you one. See, this is a staghorn stone. I have done a mini perc in this patient. So you see, this is the laser fiber. So you see, this is the stone being fragmented and it comes out through the sheath. So after the surgery, the stent is placed. This is the stent is being placed. And I have not put even the percutaneous nephrostomy tube. You can see I am just withdrawing my nephroscope. You can see this is the tract. See the stent, and there is no bleeding. So this is a very safe procedure. Patient discharged within after 24 hours. Okay? Yeah. So these are the high-end surgery. So now comes the urinary bladder stones. If a patient has got bladder stones, the 65-year-old gentleman with a prostatic enlargement, only by removing the stone, patient will not have benefit. You have to treat for the BPH also. If a young patient, 45-year-old, has a prostatic enlargement, 30 to 40 grams of prostate, so in that TURP is not done. Remove the stone and put the patient on alpha blocker. Then also if you see a patient like this, you must refer the patient for a evaluation of BPH, BPH, that is, does he need the treatment for the BPH also. Then what are the options for bladder stones? Cystolitholepexy, which is done through urethra endoscopically, or PCCL, percutaneous cystolithotripsy. Then the open removal. I'll show you one or two cases. See, this is the big stone. Can you see the stone? This is a radiolucent stone with the nidus in the center. Okay, and this is done post PCCL. You can see this, the whole kidney tray is full of a stone. And this is open cystolithotomy. This patient had undergone ectopia vesicae repair at the age of 2 years. He came to us after 22 years with a big stone. The only option is open removal. Nothing should be tried, no endoscopy, only open removal of the stone to safeguard the bladder. Then the stricture urethra. If you see patient with a straining, young patient straining, you ask the history of, does the patient has a history of trauma or urethral catheterization? So if you suspect the patient has a urethral stricture, then you should refer the patient to urologist. Like patient has a poor urinary stream, recurrent UTI, retention. The surgical options are, if it is short segment, then it should be endoscopic treatment. If it is a long segment, then it should be urethroplasty. So you see, this is a normal urethra. Here is the short segment, so endoscopic treatment can be done. And this is the pan-urethral stricture. The whole urethra is strictured. This is my patient, okay. So the buccal mucosa urethroplasty can be done. The buccal mucosa harvested and just make a urethra and put it there. So these are the steps. You can see this, the marked, and then the mucosa is harvested. I put the mucosa, buccal mucosa on the corpora, then the anastomosis is done. The post-traumatic stricture is one of the most difficult surgery in urology. No urologist wants to touch because of due to trauma, the anatomy is lost and the recurrence rate is very, very high. And also associated with erectile dysfunction after the surgery. So I had a case with a 22-year-old marine engineer. In the ship, how the door is closed, you know, the very thick metallic door comes and closes. So he was trapped in that door and sustained a pelvic fracture. So this was outside, this was in Russia. He underwent emergency surgery with pelvic beam fixation and SPC. You see, this is the pelvic beam fixation. You see the bladder, this is the MCU. The urethra is not seen below the bladder. Here in the retrograde urethrogram, you can see the contrast is not going up in the bladder. Okay, I did a progressive periurethroplasty. It takes about 4 to 5 hours, and you can see the continuity of the. So these are the most challenging cases. Then come to the cancer. If you see a patient has hematuria, patient is more than 45 years old, please do not wait. Do a sonography, routine urine, serum creatinine. If you find any mass, must be referred to the urologist for the as early as possible. So if you want, you can do serum creatinine, you can do CT urogram to see whether the tumor is the RCC, is the bladder tumor, it can be done, but treated by urologist. Now the bladder cancer. Many times I see a patient, so I had a blood in the, पेशाब में blood आया था, लेकिन दवा दिया उसके बाद ठीक हो गया. Should not be done. Patient must have a sonography. Even if the sonography is negative, patient should have cystoscopy to rule out a small bladder tumor. So the bladder cancer, cystoscopy, TURBT, if it is a superficial tumor, needs conservative treatment by intravesical therapy, by mitomycin C, gemcitabine or BCG. If it is a muscle imaging, if the tumor invades the muscle, detrusor the muscle of the bladder, then the only best treatment is radical cystectomy. I do cystectomy with a neobladder. I make bladder of a small intestine and put into the pelvis, so the patient does not have a stoma, does not have to wear a urostomy bag. Then the prostate cancer. Prostate cancer is very, very important. If you see a patient who has LUTS, lower unit tract symptoms, patient is more than 60 years of age, even if you can do, you can do rectal examination, some of you may be a surgeon, and if you can't do, then you must do a PSA also, especially in those patients who has a history of prostate cancer in the family. The PSA must be done. Then if the PSA is high, do a MPMRI. If there is shows pyrite 4, 5, then the patient is stress guided biopsy. If the prostate cancer is proved, then they refer to urologist, then either conservative or active surveillance or robotic associated laparoscopic radical prostatectomy or radiotherapy, depending on the patient choice. But I prefer surgery. So scrotal conditions, varicocele. If the patient has a varicocele with the pain, if you do semen analysis, so abnormal semen parameters, then must be treated by urologist, may require varicocelectomy. But one thing, for pain, the varicocele surgery should be avoided. Otherwise, patient will keep eating your head because patient do not respond well. So first, patient with the varicocele, only pain symptom, no other parameter, give a anti-inflammatory, give a diethylcarbamazine for maybe 10 to 2 weeks, 10 to days to 2 weeks, and they see the response. The undescended testis, if you see a patient more than 1 year with undescended testis, surgery must be done. Then the testicular torsion is a real emergency. The golden rule is it must be operated in 6 hours. No need for triple H, no need for any investigation. Directly the patient should be taken to the theater. Even the negative exploration does not harm. So urinary tract infection, if a recurrent UTI, complicated UTI, sometimes you see acute pyelonephritis, you see emphysematous. These are the urological emergency. Patient must be admitted in the hospital for IV antibiotics after sending all the investigation. So thank you so much for your patient hearing. If you have any question, I would love to take the question.
Thank you, Dr. Suresh Bhagat, for that clear and practical session on the surgical management of common urological conditions. Let's give him a big round of applause. Thank you so much, Doctor, once again. Now it's time for lucky draw.
Renal cyst, a very good question. So see, I'll tell you, after the age of 40, 30% of the patient will have some sort of renal cyst. A small cyst, 3 centimeter, 4 centimeter, don't do anything. If the cyst is very big, 10 centimeter, 15 centimeter, and the patient has symptom, it must be done laparoscopically, deroofing. Its a surgical time is 10 minutes. That's all.
Thank you, sir. Almost, ma'am. देखो पूरे घुमाए और ऐसा बस अभी बस हुए पक्का
Dr. Gaur.
Congratulations, Dr. Gaurav.
Savita ma'am. Okay. मुझे आग बंद करके निकाल तू, हाँ ऊपर, हाँ डाल. अरे वो आग बंद करके तू आग बंद. Okay done. डाल, डाल. ललिता चुनेकर है. अरे वाह. देशमुख सर. Dr. Manoj Prajapati.
Congratulations to you.
लास्ट टाइम वो लेफ्ट साइड ज़्यादा भारी था, ये बारी को राइट साइड में लगता शगुन लगा के रखा है.
Let's give him a big round of applause. Congratulations to all our 3 lucky draw winners. Now requesting Dr. Bhushan Rokade and Ms. Dr. Meena Desai to felicitate our speaker, Dr. Suresh Bhagat. Let's give him a big round of applause, guys. Would like to inform that VKGP Medcon Nexus 2026 is powered by MOC Cancer Care and Research Center, sponsored by Hiranandani Hospital, Adi Arogyam, Heart and Vascular Super Speciality Hospital, Dr. Jiten Chaudhary's Healing Touch, KT Kids, Dr. Anil Podda's One Heart, Asta Hospital, Lifestyle Studio Pharma, Rheumagen Clinic, Ruby Hospital, Sai Hospital, Ipca Laboratories Limited, Sunshine Fertility and IVF Center, co-sponsored by Gogri Laboratory, Nebula Diagnostics, Dr. Zahir Abbas Merchant, Spine Surgeon Ghatkopar, Dr. Vikas Pandey, Gastrojournalistic, ABS Multi Speciality Hospital and ICCU, APS Hospital, Trishula Lab, Pulse High-Tech Healthcare Center, Naukar Hospitals, RBM Pathology Lab, Disha Diagnostics, Dr. Malvankar Rumin Medico Surgical Hospital, Bhavya Hospital, Yashwant Hospital, Criticare Asia, and banking partner SVC Cooperative Bank Limited. Let's give a big round to our sponsors. A very big thank you to our sponsors. I would like to invite Dr. Seema Mandaukar and Dr. Sachi Ram to introduce our next speaker.
Good evening, doctors. Hope you are refreshed after the lunch and ready for the focus session. A doctor with a passion for fitness where medical meets strength and discipline. It is my privilege to introduce dynamic and dedicated clinician in the field of rheumatology, Dr. Harsh Jain. Dr. Jain is highly skilled rheumatologist with over 8 years of clinical experience, currently practicing at Naukar Hospital, Bhandup West. He has worked across multiple reputed institutions and cities, gaining extensive exposure in managing complex and challenging rheumatological conditions. He is widely recognized for the sharp diagnostic acumen, evidence-based approach, and compassionate patient care, which made a significant difference in the lives of many patients suffering from the chronic and often debilitating autoimmune diseases.
Dr. Jain's area of special interest include the management of arthritis, autoimmune rheumatic disorders, osteoporosis, and severe systemic conditions, along with advanced procedures such as joint injections and biological infusions. Academically, he has a strong foundation, MBBS from GS Medical College and KM Hospital, Mumbai, MD in Internal Medicine from the same prestigious institution, DNB in Clinical Immunology and Rheumatology from Army Hospital Research and Referral, New Delhi. Notably, during the DNB training, Dr. Jain was honored with the President Award, a recognition of his outstanding academic performance and excellence in his field. He has actively contributed to research, participated in numerous academic workshops, and has multiple publications to his credit, reflecting his commitment to advancing the field of rheumatology. इल्म की रोशनी से राह दिखाते हैं, दर्द को समझाकर उसे मिटाते हैं। रूमेटोलॉजी के इस कठिन सफ़र में हर मरीज को नई उम्मीद दिलाते हैं। विद ग्रेट ऑनर, लेट अस वेलकम डॉक्टर Harsh Ramesh Jain to share his insights and expertise. Please, sir.
Thank you for the kind and lovely introduction. The aim of today's presentation is to understand joint pains. Usually every patient who has arthritis or who has mechanical pain will come to you with more or less joint pains or muscle aches. We need to understand and diagnose them at the very onset to prevent damage actually. So arthritis is actually a symptom, it is not a diagnosis. So if we see the tail of different animals, we are able to identify the animal. Similarly, if we are able to identify the pattern of the joint pain, we might be able to pinpoint the diagnosis, whether it is arthritis, osteoarthritis, rheumatoid arthritis, or spondyloarthritis. He was a very famous painter, Pablo Picasso. He was known for his art, and he used to use cubism as to express his art. So by seeing at both these paintings, we are able to identify which one was done by Pablo Picasso. Similarly, this one, and this one. So usually what I am trying to explain here is the pattern recognition, because every time human beings, from understanding human nature to understanding different various clinical features of a disease, we learn by identifying different patterns. Hence pattern recognition is the key in identifying arthritis. So the following steps are whether the joint pain is articular or non-articular, whether it is inflammatory or non-inflammatory, and then finally identifying the pattern of arthritis. So usually if the pain is because of arthritis, it is deep or diffuse, patient is not able to localize it. The patient will have limited range of movement both on active as well as passive movements. There will be signs of inflammation like redness, swelling, crepitus, and deformity. Non-articular, you will usually have pain only on active movements. So usually patient when comes to you in the OPD will complain, Doctor साहब मेरे सारे joints pain होते हैं. The first complaint is like this. Patient will not tell you, sir मेरे small joints दुखते हैं और large joints ही दुखते हैं. So usually in inflammatory arthritis the onset is insidious. The small and large joints both are affected. It is associated with swelling. The most differentiating factor is early morning stiffness. मैं जब सुबह उठता हूँ मेरे हाथ अकड़ जाते हैं, मैं AC में नहीं बैठ सकता हूँ, fan चालू होता है तो मुझे दिक्कत होती है. The joint pains are usually additive, symmetrical or asymmetrical, and when the patient walks up in the morning and notices relief in daily activities and on exposure to sunlight, usually the pains, they worsen during winters. So if we want to summarize the differentiating factors, inflammatory joint pains will have early morning stiffness lasting for more than 30 minutes to 1 hour. There will be significant fatigue. Patient will improve after activity. Unlikely osteoarthritis, the pain worsens on activity. Patient will have extra-articular involvement, that is, patient may have involvement of lungs, heart, eyes, intestine apart from the joints, and patient definitely improves with corticosteroids or NSAIDs. So the third thing is identifying the number of joints, whether it is symmetrical, asymmetrical, whether it is predominantly upper limbs, lower limbs, or is it episodic, migratory, or additive. So understanding the patterns of arthritis, in the right image you can see the pattern is row pattern, and in the next image it is asymmetrical sun-ray pattern. Sun-ray pattern means all joints in a single finger are affected. Here all joints in a row-like pattern are affected. So the right-sided image is usually of rheumatoid arthritis, symmetrical, additive, row-like pattern. And if it is a sun-ray-like pattern, and you can see the red color indicates the affected joint, so it is asymmetric, and the sacroiliac joint is also affected, and the sun-ray pattern, which means all the joints in the finger are affected, it means the patient is having dactylitis, which is commonly seen in spondyloarthritis group of arthritis. So now if we see the different patterns, the first image is sun-ray pattern, all symmetrical, all joints are affected, which is rheumatoid arthritis. Second is psoriatic arthritis. So dactylitis is more common in psoriatic and reactive arthritis. The patients will have unilateral sacroiliitis. But if we see the third image, the whole spine is red. Any joint in the spine, the sacroiliac joint, the hip, the knee, or the shoulder can be affected. So rheumatoid arthritis means peripheral joints symmetric. Psoriatic means axial plus peripheral, with dactylitis. Spondyloarthritis means predominantly axial and asymmetric peripheral joints. And last is osteoarthritis, where the load is more on the joint, which is that means the dependent joints, which is the knee. So that is why the ankle is paired in osteoarthritis. The spine, the hips, the knees, they all are affected. Now you can see also that the CMC joint, this is the carpometacarpal joint, this is actually affected in osteoarthritis. It is not affected in any other diseases. This is how you identify the pattern of joints and make the diagnosis. So coming on to the cardinal symptoms of connective tissue diseases, if the patient along with arthritis tells you that मुझे मुंह में बार बार छाले हो रहे हैं, धूप में जाने पर rash हो रहा है, that is the butterfly SLE rash, a patient is losing hair, or whenever he or she goes out in the sunlight, develops redness over the face, or there is dryness of mouth or sicca, or there is bluish discoloration of nails, bluish discoloration of digits of the fingers, puffy fingers, proximal muscle weakness, prolonged fever or dry cough, it means that patient is not having plain arthritis. It means there is something underlying systemic issue going on. So now we will understand everything on a case-based basis. So a 40-year-old female presenting with erosive polyarthritis, starting with small joints of hands and then involving the large joints in a symmetric fashion. So here it is inflammatory, additive, symmetric polyarthritis involving the small and large joints. It is erosive, it means rheumatoid arthritis. Rheumatoid arthritis, spondyloarthritis, osteoarthritis, they all are erosive, but here the pattern is symmetric. Now a 55-year-old female is having non-deforming symmetric polyarthritis. Arthralgia is more than arthritis. It means the patient is having joint pains, but on examination you are not able to find actual arthritis. The patient also has fatigue and poor dental hygiene. It means the patient was having Sjogren's disease. A 25-year-old female with non-deforming symmetric polyarthritis with recent onset hair fall and photosensitivity. The clue here is photosensitivity and alopecia. It means a young female which might be suffering from lupus, that is SLE. A 30-year-old female with asymmetric oligoarthritis, predominantly involving the lower limbs with history of low back pain, is suggestive of spondyloarthritis. A 55-year-old male with metabolic syndrome presenting with recurrent episodes of acute onset pain involving the foot lasting for 3 to 5 days. It means patient is having acute onset lower limb arthritis. It is gout. Gout usually presents as acute attacks of single joints. A 40-year-old female with deforming polyarthritis involving small and large joints with DIP joints. So always remember, DIP joints are always involved in osteoarthritis and psoriatic arthritis. But the young female, the age is 40. So in 40, osteoarthritis should not happen. So this is psoriatic arthritis. So explaining the iceberg phenomena, we often understand that patient coming to joint pains rheumatoid factor positive is rheumatoid arthritis, but that is something wrong because we actually are not able to find the wolf which is there along with the sheep. So rheumatoid factor doesn't mean rheumatoid arthritis. It can be present in lupus, mixed connective tissue disorders, chronic infections, chronic liver disease, and also healthy individuals. So there is often a fight understanding between the clinical picture and the serology. So case 1 is lumps and limps. A 65-year-old male presented to you with multiple joints for last 6 years. He is having pain and stiffness. Initially started with episodes of pain and swelling in the great toe, which means the episode started as monoarthritis. If the great toe is involved, it means podagra. Understand the patient is having multiple comorbidities and also consumes alcohol and mixed diet. You find the swollen joint count, the tender joint count is 10, 12, and patient actually has multiple subcutaneous nodules. You may confuse this as rheumatoid arthritis with rheumatoid nodules, but understand the picture was, it initially started as monoarthritis. Here the rheumatoid factor is positive, but anti-CCP is negative and HLA-B27 is also negative. So anti-CCP is much more specific marker than rheumatoid factor, and we should order anti-CCP rather than rheumatoid factor. Here the uric acid was quite high. The diagnosis, you can see these are multiple subcutaneous nodules. They also mimic as rheumatoid nodules. But when you remove the fluid from this tophi, you can see a rat bite erosion like picture on the x-rays, which is commonly seen in gout. So when you do a musculoskeletal ultrasound, you can see a double contour sign. Usually the cartilage appears black on the ultrasound, but when the uric acid is deposited, you can see 2 semilunar lines, which is the double contour sign. So if I aspirate the fluid, it appears milky, and if I see it on microscope, you can see like it's like Diwali. The needle-shaped crystals are throughout there in the synovial fluid. So case 3, nails tell the tale. A 30-year-old female presented with multiple small joint pains, chronic heel pain, pain and stiffness in low back. Now understand this, multiple small joint pains, heel pain. So usually Achilles is attached to the heel. It means that patient is telling us that he or she is suffering from enthesitis, and she also has low back pain and family history of psoriasis. There is dactylitis, nail pitting, ESR, CRP are normal, rheumatoid factor again is positive, anti-CCP is negative, uric acid is elevated. Understand, uric acid here is elevated because of the increased skin turnover in psoriasis, not because of gout. So the diagnosis here is psoriatic arthritis. Here you can see the digit actually appears like a sausage. It is completely swollen. Yes. So there are some pitting in the nails also, which is pointing towards psoriatic arthritis. You can see a reverse omega sign because of new bone formation in the psoriatic arthritis. So this actually is syndesmophytes. You can see the two vertebrae are actually joined because of the new bones. Just this is a syndesmophyte connecting two vertebral bodies because of the new bone formation. So these are actually syndesmophytes, and here you can see the SI joint is actually completely sclerosed. You cannot see the joint space. So this patient was having axial as well as peripheral arthritis because of underlying psoriatic arthritis. Case 4, when tears and saliva run dry, a 55-year-old female presented with multiple joint pains, dryness of mouth and eyes, and severe fatigue with poor dental hygiene. Multiple caries were there at atypical sites. You found arthritis on examination. The inflammatory markers are elevated. Again here the rheumatoid factor is positive. The clue here is the globulins. Globulins means immunoglobulins, which are elevated, and anti-CCP is negative here. So on examination, you find that there are atypical dental caries. We need to understand what is atypical. Actually, the front teeth are usually not affected because of the cavities. Usually it is the molars which are affected. So these are the actual atypical sites which affect Sjogren's. So on salivary ultrasound, this is a normal ultrasound, but if you do the ultrasound of the affected glands, you can see multiple cysts, the radiolucent areas, the black areas which are there in the gland, which are actually suggestive of cyst filled with saliva. When you do the biopsy of the lip, you will see lymphoid aggregates, which is suggestive of lymphocytic infiltration, pointing towards salivary gland inflammation. This is how you make the diagnosis of Sjogren's. Coming on to the next case, the clues in the sores. A 30-year-old male presented with arthritis of knees and ankles for 10 months, and he also had tender erythematous nodules and pustules over his legs, and he had history of cerebral venous sinus thrombosis. On examination, swollen joint count, tender joint count is 2/4. He has painful oral and genital ulcers. ESR CRP is elevated, but now RF, anti-CCP, ANA by IF is negative. Usually females have common autoimmune diseases. Females are more prone to autoimmune disease. But whenever you find that any male patient who is having recurrent oral genital ulcers and arthritis, always think of Behcet's. So this patient had genital ulcers as well as oral ulcers, and these are actual erythema nodosum. Whenever you find red tender nodules, always consider erythema nodosum as the diagnosis. So what we did is a pathology test. What is pathology test? Actually, we take a 21 mm gauge needle and irritate the skin. We poke the needle and we leave it for 48 to 72 hours, and this results in pustular lesion. It is similar to the test like Mantoux. You give an antigen and there is a reaction, but here the skin is hypersensitive. There is a T cell mediated inflammation which leads to formation of pustules. So, coming on to case 6, whispers in the X-ray. 70-year-old male presented with acute onset pain and swelling in the right knee for last 5 days, associated with inability to bear weight, history of osteoarthritis in both the knees, and patient is also type 2 diabetic. His BMI was 35, and on examination he had a swollen, warm and tender left knee. Restricted range of movement in all planes, and crepitus was present. CRP was around 50. Uric acid is 3.5. Anti-CCP HLA-B27 is negative, and synovial fluid shows 50,000 WBCs. Often this will be confused as septic arthritis. Patient will be started on antibiotics. But now understand this, the culture was negative. Now you see the X-ray. Here, if we see, there is a small white spot inside the cartilage, which is actually indicating calcium deposition, which means chondrocalcinosis. So this patient had osteoarthritis and then suddenly developed acute onset knee monoarthritis. So we are happy when the calcium is in the bones, but when calcium is at other sites, it actually creates a problem. So when we examine the synovial fluid under polarized microscopy, we can see such rhomboid shaped crystals, which is suggestive of calcium pyrophosphate deposition disease, which is also known as pseudo-gout. The difference between gout and pseudo-gout is that pseudo-gout often affects the large joints, which is knee or ankle, and gout will often attack the small joints, which is MTP joints at the onset. Coming on to case 7, a triad of trouble. 40-year-old female presented with acute onset pain and swelling in both the ankles, tender spots on foot and leg for last 7 days, no history of fever, weight loss or cough. If a similar patient comes to me, I make the diagnosis of bilateral lower limb predominant arthritis with erythema nodosum, as we saw earlier in the case. Patient has no history of fever, weight loss or cough. It means I am trying to rule out tuberculosis, as tuberculosis can also present as lower limb arthritis with erythema nodosum and also leprosy. On examination, I didn't find any thickening of the nerves or hypoaesthetic patches which are seen in leprosy. Patient acute phase reactants were elevated, TB gold and Mantoux were negative. I saw ankle is swollen and he is having tender erythematous spots. On X-ray, you can see there is hilar prominence, which is suggestive of bilateral hilar lymphadenopathy. On examination, on the histopathology, you find granulomatous inflammation, which is non-necrotic. So non-necrotic inflammation is usually seen in sarcoidosis, and this triad of erythema nodosum, hilar adenopathy, and arthritis is known as Lofgren syndrome. Coming on to case 8, a senior struggle with stiff mornings. A 60-year-old male presented with pain and stiffness in both the shoulders for last 3 months. He was diagnosed as frozen shoulder and was given intra-articulars in both the shoulders, had no relief. Similar complaints were observed in both hips and thighs for last 1 month, associated with low-grade fever, weight loss and malaise. At times, these patients are diagnosed as you are having frozen shoulder or you are having osteoarthritis or rheumatoid arthritis. But understand that rheumatoid factor anti-CCP was negative, tumor markers were negative, ESR, CRP were elevated, indicating that this patient was having inflammatory arthritis. But what is the diagnosis? If we see the MRI, we can see the fluid which is here around the bicipital tendon as well as in the capsule of the shoulder joint, near the capsule of the shoulder joint, which is suggestive of mild shoulder effusion as well as bicipital tenosynovitis. And patient was given 5 mg prednisolone, and next morning patient improved dramatically. So this patient was actually suffering from polymyalgia rheumatica, not frozen shoulder, not rheumatoid arthritis, not osteoarthritis. Daily dose of heat wave. A 30-year-old male presented with pain and swelling in multiple joints for 1 year, preceded by a history of pharyngitis followed by high-grade fever, daily spikes with afebrile periods, no response to multiple courses of antibiotics. Understand that if you get a history of pharyngitis before the onset of arthritis, do not go for ASO titers. He is a 30-year-old male, unlikely to suffer from rheumatic fever. So on examination, you see that the wrists are already fixed. There is deformities. Patient has moderately enlarged spleen and liver. There is decreased air entry on examination. Again, the inflammatory markers are elevated. The clue here is neutrophilic leukocytosis. LFT is deranged, SGPT is 80, ANA is positive, homogeneous, which is falsely positive. Rheumatoid factor anti-CCP is negative, ferritin is 8,500. So the clue here is neutrophilic leukocytosis and high ferritin. On X-ray, you can see serositis, that is bilateral pleural effusion. On X-rays, you can see there is sclerosis in bilateral wrist. The wrists are predominantly involved rather than the small joints of hands. This gives us a clue that it is unlikely rheumatoid arthritis, which involves the PIP and the MCP joints rather than the wrist. So this patient was having adult onset Still's disease. Pain everywhere. We always face this difficult patients. 30-year-old female having multiple joint pains. There are still no deformities. She has been suffering from same joint pain since last 5 years. Widespread pain. Wherever you touch, she will say that this area is painful. She is having disturbed sleep, constipation, headaches. The rheumatoid factor is positive here. And anti-CCP is negative, CRP is negative. What will you do? Will you start methotrexate? नहीं करना था. So when we did a musculoskeletal ultrasound for this patient, it was absolutely normal. So she was actually suffering from fibromyalgia. What we understand is that females usually have high emotional intelligence, and the ability to process pain is different compared to males. And if we are not attributing, or if we are not solving that pain where that is coming from, it leads to pain amplification, and it changes the whole scenario. So how we explain the patient is that the gut-brain immune axis. If any one is affected, your brain is affected, your gut will get affected, and your immunity will always affected. So what these patients require is tender, loving care. They should regularly go to the gym. They should take some mood stabilizers, melatonin, and lose weight. So this is my team at this was my team at Army Hospital. I wanted to express sincere thanks and gratitude to my department who have made me a rheumatologist now. He was my guide, Dr. S. Karthik, Group Captain S. Karthik. So thank you. Together with my wife, Dr. Srushti Joshi, we have started a Rheuma Gynae clinic at Bandup. Thank you. Thank you so much. So actually, when we can start methotrexate is if you are sure that the patient is having inflammatory polyarthritis and you have ruled out underlying infections and you have made a diagnosis of rheumatoid arthritis, you can start methotrexate. Dose, it depends on the patient to patient. If the patient is an adult patient, you can start from 15 milligrams per week. I often see prescriptions of 2.5, 5 milligrams, but that is a very minimum dose. Usually methotrexate was used during treatment of cancer. So the high dose methotrexate is 1000 milligrams per meter square. 15 milligram is just a low dose. Actually, if you start, but you have to monitor it monthly, on a monthly basis. You can start actually. Thank you. Thank you.
Thank you so much, Dr. Jain, for making arthritis management so relatable and practical through real life scenarios. We truly appreciate it. Let's give a big round of applause for Dr. Jain. Now it's time for 3 lucky draws.
Almas madam, kidhar baithi? डॉक्टर रणधीर सर, लगता है कुछ तो कह रहा है उधर, लिम्बू फिराया लगता है, ऐसा लग रहा है मेरे को राइट साइड.
Congratulations.
Congratulations sir. विजय सर.
Time for second lucky draw.
डॉक्टर सुहास भोसले.
Congratulations, Dr. Suhas.
सुहास भोसले, जगदाळे नाही बाबा.
And now the third lucky draw.
आस्था ये आस्था इकडे. देखते हैं आस्था लकी है क्या आपके लिए.
डॉक्टर निकिता रोकड़े.
We have bumper prize like announcer करते हैं लोग जा कम हो रहे हैं. So what we have bumper prize? TV, speakers, electronics, sound systems.
Thank you.
Okay. Thank you so much. Now requesting Dr. Sunny Vaikode and Dr. Suhas to felicitate our speaker, Dr. Harsh Jain. Dr. Suhas Jagdare. A reminder to all, after these 2 sessions, we have bumper prizes, and in that we have speakers, LED, and what all. I don't think so you will want to miss on this chance. So requesting everyone, अभी इतना रुके ही हो सुबह से तो और थोड़ा और रुक जाइए थोड़ा टाइम और अपना बम्पर प्राइज लेके ही जाइए. क्या पता आप वो लकी विनर हो जाए. Now I would like to invite Dr. Parth Pradhan and Dr. Nikita Rokhare to introduce our next speaker.
Good evening, everyone. It is my pleasure to introduce a highly dedicated specialist in pediatric healthcare, Dr. Swati Krishna.
Dr. Swati is a pediatric hemato-oncologist with a MD in pediatrics and fellowship of National Board in Pediatric Hemato-Oncology. She is currently practicing at MOC Cancer Care Research Center across Ghatkopar, Thane and Mulund, where she plays a vital role in providing advanced care to children. Her medical journey began with her MBBS from Shimoga Institute of Medical Science in Karnataka, followed by her MD in pediatrics from Lokmanya Tilak College, Mumbai. She further completed her FNB at prestigious BJ Wadia Hospital for Children, a center well known for excellence in pediatric healthcare.
Dr. Krishna brings extensive experience in diagnosing, treating, and managing a wide range of pediatric oncology conditions, including leukemia, lymphoma, neuroblastoma, and other solid tumors. She is also highly skilled in administering chemotherapy and targeted therapies tailored for children. Please join us in warmly welcome Dr. Swati Krishna, ma'am.
Welcome, ma'am.
Thank you so much for the wonderful introduction. So today I am going to discuss about the introduction. Basically, we'll discuss about the red flags which we cannot miss when a pediatric patient walks into our clinic, and I'll walk you through the stories of 3 of my patients and their treatment journeys. So we always believe that childhood cancers are very rare. Many of them fail to believe when I tell them that children do get cancers, even the parents and physicians. It is often believed that cancers occur only in adults. So childhood cancer is actually only 4%, the incidence is between 4 to 5%, but it is not as rare as we used to think. So globally, the incidence is as high as almost 4 lakhs, and in India, which accounts to 75,000 to 1 lakh of the cases diagnosed every year. So in children, which cancers do we see most commonly? So blood cancers are the most common cancers that we diagnose in children. This is followed by lymphomas and brain tumors. So these 3 are the most common cancers we see in children. So 1 in 3 children who comes to the clinic will be diagnosed with a blood cancer. And if you see the incidence, 0 to 4 years. So this is a very young age group. In fact, a child who's newborn, he can also have cancer, he or she. So newborns can get blood cancers, they can get soft tissue tumors, and some tumors like germ cell tumors are also very common in newborns. So how are childhood cancers different from adults? The origin itself is very different. So the origin of childhood cancers, the tissue is the embryonal tissue. In adults, we see more of carcinomas, like you must be aware that CA lung, CA breast, CA cervix, this is very common in adults. But in children, we don't see any of these cancers. So all the cancers predominantly originating in children are from the embryonal tissue. And the cancers in children, they have a tendency for a very rapid progression. This doesn't mean that any tumor which has a very indolent presentation, like Hodgkin's lymphoma, and there are many low-grade brain tumors which can have a very, very slow progression. So apart from that, whenever we diagnose a child with cancer, very often the parents ask, could we have done something which could have prevented the cancer? Unfortunately, in children, we don't identify any such factors. Very rarely, some of them can have some predisposition syndromes. Like you must have heard of neurofibromatosis, tuberous sclerosis. So these are some tumors which will predispose to brain tumors. So apart from that, unfortunately, in children, we cannot prevent cancers. But if there is a family history of any young relative in the family, be it the mother's side or the father's side, who had cancers below the age of 40 years, then that will be an important screening point for us. We will advise clinical exome, which can help in diagnosing some hereditary predisposition syndrome. So this is the first case, a febrile anemic child, a very common scenario which we often see. So this child is a 7-year-old male child who has high-grade fever for 2 months. There is family history of COX. The mother lost her husband just 2 years ago due to pulmonary tuberculosis. So in this mother, it was very challenging for her because she didn't have anyone to support the child during the course of treatment. It was the mother who was always bringing the child for the treatment. So the fever was almost high grade. Almost every day he was having a fever spike. He was treated with antibiotics. He was treated for typhoid. And because there was a history of COX, a lot of investigations for COX was done and everything was negative. So when the child came to us, the complete blood count was showing a very scary picture because the hemoglobin was 2.5 grams, very low hemoglobin. The child came with respiratory distress. His WBC was high, not very high, but significant enough to fit into the diagnosis of leukocytosis. Platelets were low. The peripheral smear. So the peripheral smear is a very important clue for us when we think of leukemia. So whenever we advise a child or screen the child for leukemia, we always advise for a complete blood count with peripheral smear. So this child had almost 75% blasts. So blasts are nothing but the cancerous cells. So whenever there are blasts, it is mandatory for us to do a bone marrow to confirm the type of leukemia. So we did a bone marrow and the bone marrow samples were sent for flow cytometry. The flow cytometry diagnosed the child with pre-BALL. So pre-BALL is the most common cancer that we see in children. And it is also one of the blood cancers which have a very good prognosis. So in this peripheral smear, you can actually see a lot of blast cells. These are the cancerous cells. They are not your normal lymphocytes. The nucleus is very large. So when the nucleus is occupying almost 20% of the cell size, they are blast cells. So what are the important red flags that we need to screen for when the child walks into the clinic? Weight loss. So in children, if you see, weight loss is not a common symptom. The parent may keep telling that the child is not gaining weight, but losing weight can never be normal. So how much weight loss is significant? So that is why there is a definition for significant weight loss. If a child has lost more than 10% in the last 3 to 6 months, it is significant and it needs further investigations. So morning headache. Very often children complain of headache and we dismiss that this is just a simple excuse that the child is giving. But morning headaches means that the child's intracranial pressure is high. So they can also have the headache with vomiting. So headache with vomiting is a definite red flag. Apart from that, constant tiredness. This is again a very common symptom that children present with. So if the child is screened for anemias and there is no nutritional anemia and still he is complaining of constant tiredness, we need to watch out for other things as well. So pallor. Pallor again, persistent pallor when nutritional anemia has been ruled out, still the child is appearing pale, can never be normal. So petechiae or bruising. If there is bruising which is spontaneously appearing without any history of trauma, so this cannot be normal. So when do we have to evaluate for, like fever is a very common symptom, right? So if the fever is persistent, it is there for more than 2 weeks persistently, high grade fever, and all the infections, all the tests for infections have been done and everything has come negative. So this is the cutoff when we have to think beyond infections. The swelling can be either abdominal swelling or it can be a lump anywhere in the body. So any lump anywhere in the body, when we don't know the cause, it has to be evaluated. So bony pain, again very commonly children complain of pain. So this is a very non-specific symptom. But a child who's complaining of pain which is so severe that he is not able to carry on his routine activities, or it is causing him to, or his routine sleep is getting disrupted. So this cannot be normal. So this bony pain has to be evaluated. So I would say that if there is more than one symptom in this which is persistent, or more than 2 symptoms, it is definitely a red flag which has to be screened. So when do we stop chasing infection and we start investigating? So in the CBC, we look at the hemoglobin. A hemoglobin below 10 grams or on subsequent follow-ups, there is a fall in the hemoglobin. So this has to be investigated, because a simple nutritional anemia, when the child is on supplements, the hemoglobin cannot fall unless there is blood loss. So a low hemoglobin, a rising WBC, more than 50,000 or below 4,000. So cytopenia, any cytopenia is a red flag. And in the CBC, we always look at the neutrophils. Any neutrophils, when the neutrophils are falling, or in the subsequent follow-ups, we notice that the neutrophil percentage is dropping down. This cannot be normal. So any thrombocytopenia, even if it is mild, like a platelet count of 1.1 lakh or 1.2 lakhs, so that is also not normal. It has to be investigated. So in the CBC, we always have, all the CBC reports give us the MCV and MCH. So that is an indicator of the size of the RBC. So when the MCV is normal or high MCV, this means that this is not a simple nutritional anemia, because always iron deficiency anemias or even other deficiencies, apart from vitamin B12, which will have high MCV. So iron deficiencies will always have low MCV. So normal MCV has to be investigated. So this was another child, a very small lump, like you can see in this picture. He is a 1.5-year-old boy with a thigh swelling in the medial aspect of the thigh. So this was noticed by the mother while giving the child a bath. There was no history of trauma and it was not painful. The child was running around and doing all his routine activities. And this was probably just a month when they noticed the swelling. They did not neglect. They immediately brought this to the notice of the pediatrician, who advised a USG, and the USG revealed that there's a firm mass. There's a firm mass which was measuring almost 5 centimeters, and there were no lymph nodes palpable. The child did not have any swelling elsewhere in the body. So we often think that any swelling which is painless is normal, but most of the swellings in cancerous swellings are actually painless. That is the reason why they get missed very frequently, because we often believe that only when it is painful it has to be addressed. So painless swelling means that it may not actually be benign. So a swelling which is persistent beyond 2 weeks has to be investigated. So following a USG and a biopsy, this child was diagnosed with a rhabdomyosarcoma. So this is one of the common soft tissue sarcomas that we see in children. It was very surprising when we did the PET scan. This tumor had already metastasized to the vertebrae. This onset was only 1 month. Still the tumor was quite aggressive and it had already spread to the vertebrae. So this means that the child is going to undergo 1 year of chemotherapy. He is going to undergo surgery, and also he is going to be requiring radiation. So the course of treatment is going to be for at least a year. So sarcomas are quite rare in adults, but in children they are very common. So we see almost 15% of childhood cancers are sarcomas. So they can be either from the soft tissue or they can be in the bones. So in the bones, the sarcomas that we often see are Ewing sarcoma and osteosarcoma. And in soft tissue, the most common sarcoma is. So as you can see here, when it is localized, the outcome rates are excellent. It is close to 80%. If it is metastatic, as in this child, the outcomes will be ranging up to 65 to 70%. And in osteosarcoma, which is again a very common tumor, the outcomes when it is not metastatic is 75%. So children actually do very well when they get diagnosed on time, receive chemotherapy, and sometimes in sarcomas they also need surgery. This is one like a very very common situation that we encounter, not just in a pediatric patient, even young adults present with lymphomas. So a 14-year-old child who had history of high grade fever for close to 6 months to 1 year. So this child's complained of constant fatigue and he had huge swelling in the neck and axilla. He was empirically treated for COX for close to 6 months, and when there was no improvement even after 6 months of therapy, that is when the child was referred to multiple places and finally an excision biopsy was done, and the biopsy revealed that this was a Hodgkin's lymphoma. So Hodgkin's lymphoma is one such tumor which can be extremely slow growing. So this tumor, when we tell the parent that this is a cancerous lesion, they fail to acknowledge because they always believe that cancers are something very acute. But Hodgkin's lymphoma and certain low-grade brain tumors can have a very indolent course. So any lymph node which is persistent for more than 4 weeks, or the size is more than 2 centimeters, it is always better to get a local imaging and plan biopsy. So when we did a PET scan, it was an extensive disease. The child had a nodal disease, he had splenic involvement and a bone marrow involvement. So the stage was 4. So after 2 cycles of chemotherapy, like you can see here, this was the initial PET scan which showed extensive disease. So just 2 cycles of chemotherapy and achieved complete metabolic response. So that is why Hodgkin's lymphoma is one such disease which responds very well to chemotherapy. And these patients need radiation as well. In this case only because it was a stage 4 tumor. Otherwise, most of them need only chemotherapy. So the 5 rules which I always tell at the end of my presentation is that when any child is presenting with any red flags, plan investigations early. Plan local imaging if you are thinking of a sarcoma. And this complete blood count definitely will help with a peripheral smear if you are thinking of blood cancers. Don't empirically treat the child with antibiotics when there is no focus of infection. It is only going to delay the entire process of getting the diagnosis early. And always careful clinical examination. A liver spleen is something that when a liver and spleen is enlarged, and if it is significant, it cannot just be any routine infection. It is definitely something beyond that. And one of the most common practices that we see is giving steroids before the diagnosis. So especially the immune thrombocytopenias, which is one of the common conditions that children usually get diagnosed with, where only the platelets are affected. The treatment is steroids, but not all immune thrombocytopenias, thrombocytopenias are due to ITPs. So if steroids are given empirically without doing a bone marrow, we may actually miss the diagnosis. Apart from this, it is a very common practice to give transfusions, assuming that most of the anemias are due to iron deficiency anemias. So this is also a very challenging situation because when the child is transfused, the subsequent investigations are going to get delayed and hence the diagnosis is going to get delayed. So I want to end the talk by saying that 3 children, 3 different cancers, and the most important lesson which I wanted to share here is early suspicion, early CBC, early referral, which will definitely help in shaping their future. Thank you so much.
Thank you so much, Dr. Krishna, for handling such an important and sensitive topic with so much clarity. Thank you so much. Let's give a big round of applause once again. Now it's time for lucky draw.
बाउल किधर है?
Pokaria.
Congratulations.
Gaya, Bahari. Surendra Upadhyay. Dr. Pramod Pandey.
Let's give him a big round of applause.
Vijay. Sorry.
And the third winner is going to be all years waiting to hear the name.
Dr. Manoj Yadav.
Congratulations, Dr. Manoj. Congratulations to all the 3 lucky draw winners. Now requesting Dr. Prashant Shinde and Dr. Pal Pradhan to felicitate our speaker, Dr. Swati.
Dr. Nitin Singh. बच्चे ये वाला इसलिए नहीं अंदर दे रहे हैं
मैडम अभी तक लगा नहीं बम्पर 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 का नहीं मिलता मेरे जैसे मेहनत का मिलता
Congratulations.
काम करता हूँ नेक्स्ट राउंड आपके पास
Requesting Dr. Prashant Shinde and Dr. Pal Pradhan to felicitate our speaker, Dr. Swati Krishna. Let's give a big round of applause. Once again, I would like to say VKPGP Medcon Nexus 2026 is powered by MOC, sponsored by Hiranandani Hospital, Adi Arogya Hospital, Heart and Vascular Hospital, Asta Hospital, Lifestyle Pharma, Dr. Harshen, IPCA Laboratories Limited, Saigare Hospital, Dr. Jitin Chaudhary, KT Kids, Dr. Anil Koddar, One Heart, Ruby Hospital, Sunshine Hospital, co-powered by Gogri Lab, Nebula, Dr. Zahir Abbas Merchant, Dr. Vikas Pandey, APS Hospital, Trishala Lab, Naukar Hospital, RPM Pathology Lab, Pulse High Tech Imaging Center, Malvankar Hospital, Bhavya Hospital, Criticare Asia Hospital, Disha Hospital, and banking partners SVC Cooperative Bank. Let's give a big round to our sponsors. A very big thank you to all our sponsors. And the last session, and for what we all are waiting for, is going to be announced, that is bumper. So I would now like to invite Dr. Mazid Sheikh and Dr. Shobha Singh to introduce the speaker for our last session.
लास्ट सेशन है पब्लिक जो बाहर खड़ी है अंदर बम्पर प्राइस का होगा ड्रॉ सोच समझ के चले जाना बाहर एक चाय के चक्कर में बाकी कुछ मत करवाना समझ में क्या मैं तो बस चाय पीते रहो फिर वो खुशी हो या कम पीते रहो चाय तुम सदा बनो
न्यूरोसर्जरी लेक्चर डॉक्टर पार्थ सारथी चौहान ही इज MCH न्यूरोसर्जरी MS जनरल सर्जरी with over 10 years of experience in medical practice. Dr. Parth Sarthi Chauhan is a full-time consultant neurosurgeon at Adi Aragyam Super Specialty Hospital, Mumbai. He completed his MCA Neurosurgery from Bombay Hospital and Institute of Medical Research Center, Mumbai, under the guidance of the eminent neurosurgeons like Dr. C.E. Dev Pujari, Dr. Sunil Shah, Dr. K.K. Turel and Dr. Vikram Karmarkar. After completion of MCH, he has worked at Bombay Hospital for 2 years as a clinical associate.
Further on, he went on to pursue his fellowship in the endovascular and the cerebrovascular neurosurgery from the Fujieda University of Japan under the internationally acclaimed neurosurgeon Dr. Yoko Kato. He has a vast experience in performing all kinds of surgery ranging from the craniotomies and cranioplasties, neuro-oncology, endoscopy, brain and skull-based surgeries, spine surgery and a special interest in the endovascular and the cerebrovascular surgeries. So please welcome.
Yeah, good evening everyone. I am Dr. Parth Sarthi Chauhan, consultant neurosurgeon working at Adi Aragyam Super Specialty Hospital, Vikhroli, Mumbai. Today this is the last session, so I don't want you to bore you in a very boring topic. So in one of the last meeting, few of the GPs have suggested me that sir, why don't you guide us for the very common neurosurgical problem which comes to us in a day-to-day practice. So that's why I have chosen this topic. It's a common neurosurgical problem in general practice, when to treat, when to refer. So why this topic is important? GPs are the first point of contact. 70 to 80% of the patient with neurological symptoms first consult a general practitioner. Early recognition saves function and life. Common presenting complaint which usually with patient comes to the general practitioners are headache, back pain, limb pain, giddiness, seizure, limb weakness and bowel and bladder complaints. These symptoms may appear benign but can hide serious conditions like brain tumor, subarachnoid hemorrhage, spinal cord compression or major vessel blockage. Here you can see on the left side of the corner there is a large meningioma sitting in the right frontotemporal region which required surgery for the cure of the disease. And the second image, there is a subarachnoid hemorrhage because of the rupture of the aneurysm. Patient was came with the GCS of 3. Patient could not be revived in such condition. Third image, you can see the very large disc at the C4, C5 level, along with the ossified ligamentum, flavum, which leads to the cord compression along with the cord edema at this level. Patient has presented with bilateral lower limb weakness along with the upper limb weakness and bowel bladder involvement. On the fourth image, you can see there is the MCA artery which is completely blocked. The patient has presented with the right side upper lower limb weakness and difficulty in speech. Within 4.5, patient has came to the hospital within 4 hours of the symptoms. So immediate CT angio followed by DSA was done and patient thrombectomy was done. Though patient remained with some weakness on the right side of the upper and lower limb, but gradually he improved with the treatment. General principle when patient comes to general practitioner: mild, non-progressive symptoms like headache, which is along with non-radiating backache, and there is no neurological deficit and no red flag signs or typical clinical pattern, good response to initial treatment. Refer if progressive symptoms like severe headache or with or without nausea and vomiting, motor weakness, sensory loss, seizure, giddiness, vision loss, imbalance while walking and repeated history of fall. Any neurological deficit like unequal pupil, altered consciousness or behavior, memory disturbance, diagnostic uncertainty, weakness in any limb or no response to treatment, refer such patient. If you find a deficit, don't sit on it. These are the most common red flag signs which you usually see in a patient when it comes to any general practitioner, which is sudden onset of any severe symptoms, night pain or early morning symptoms, fever, weight loss. There is a history of cancer in the past, history of trauma. Patients are in any age of extreme, like young patient less than 5 years of age, or elderly patient more than 70-75 years of age. There is a blurring of vision along with a vision loss or bowel bladder complaint. I'll start with few of the most common complaints with which patient comes to general practitioner. That is low backache. Most commonly we call it as a sciatica. The common cause for this is mechanical back pain, lumbar disc herniation. Mechanical back pain is most commonly because of the muscle sprain or muscle strain. If pain is less than for 4 to 6 weeks of duration and there are no neurodeficit and no red flag sign, these patients can be treated at a general practitioner level with NSAIDs, muscle relaxant or physiotherapy. Red flag symptoms which include bowel bladder involvement, which usually depicts that the patient is having cauda and aqua syndrome, patient is having saddle anesthesia, patient is feeling numbness in perineal region, which is also giving you a diagnosis toward cauda equina syndrome. If patient is having progressive weakness and increasing in motor weakness, there is a severe compression at the spinal cord level or there is a tumor. If patient is having fever with weight loss and there is a backache history, patient is having spinal tuberculosis or maybe some malignancy. Here is the clinical tip is back pain with bladder symptoms, think about cauda equina. Now, what is cauda equina? Cauda equina is a bundle of nerve fiber which start at the level of L1, L2, where the spinal cord finished and the only nerve roots which goes out from the neural foramina and supplies the lower limbs. So, lower limb, this patient come with lower limb complaint like motor and sensory weakness, bowel and bladder complaint or sexual dysfunction. Common causes which causes cauda equina syndrome is a massive lumbar disc herniation, which is the most common, spinal tumor, which could be primary or metastatic because of the any lesion in the lungs or maybe in the kidney. Trauma, which is because of the fall from height or maybe road traffic accident, there is a burst fracture of the spinal vertebral body. Epidural abscess, inflammation or inflammation or hematoma, which could be because of post procedure or anticoagulation, and spinal stenosis, which is a rare acute cause for cauda equina syndrome. Classical clinical features here could be severe low back pain, bilateral leg symptoms, saddle anesthesia, bladder dysfunction, bowel dysfunction and sexual dysfunction. Examination, you may find reduced perineal sensation, absent bulbocavernous reflex, decrease in anal tone and lower limb element sign, and reflexes there will be hyporeflexia in the lower limb. Second symptom could be motor weakness. Most common cause for a motor weakness will be stroke, cord compression, tumor or disc prolapse. At GP level, maybe it's difficult to manage such patient and patient may require referral because this patient comes with a history of sudden onset of progressive weakness associated with speech and vision. The chances of strokes are very high and patient may require immediate intervention for the further management. Any weakness, always take expert opinion. Seizure. Most common causes of seizure could be epilepsy, infection, trauma, tumor or metabolic. In metabolic, it could be because of the hypoglycemia or hyponatremia or maybe some of the encephalopathy. In a known case of epilepsy, with good control with medication, you can treat at general practitioner level. Rest of the cases where patient is having first seizure of life, focal seizure, seizure in the middle age with no past history, post-traumatic seizure, persistent altered sensorium or suspected structural cause or status epilepticus. Patient will require further investigation and as per that, it will require further management. Altered sensorium. Possible cause of altered sensorium could be trauma, stroke, infection or metabolic. At general practitioner level, you can try for airway breathing and circulation, and patient will require further management at the higher center with the expert care under neurologist and neurosurgeons. Don't try to fully diagnose such case with altered sensorium. Try to stabilize the case and refer. Gait disturbance, imbalance and giddiness. Most commonly, patient comes with the vertigo or giddiness at your level. You can confirm the diagnosis by doing the Dix-Hallpike test, and if this Dix-Hallpike test is the positive, then you can treat it as a vertigo by Apple's maneuver and beta-histine and other medication. If patient is having progressive imbalance, frequent fall or associated weakness, patient will require further management of MRI, cervical spine and maybe brain also. If you are seeing that patient is having a suspecting the cervical myelopathy or normal pressure hydrocephalus, patient will require further management as per the symptoms. Imbalance in elderly is not always vertigo. Neck pain. Most commonly, neck pain is because of the muscle strain, that is because of trapezitis, cervical spondylosis or cervical radiculopathy. Mild pain with no neurological signs and symptoms, patient can be managed with muscle relaxant, maybe gabapentin, pregabalin and other medication if you are suspecting of a radiculopathy. And if there is a patient having a severe stenosis or there is a myelopathic changes, patient will require further intervention, further investigation with MRI, maybe with the CT cervical spine and management accordingly. If patient is having neck pain along with hand clumsiness, like fine motor movements are difficult from in hand, patient is having myelopathy until proven otherwise. Now I'll come to the point of head injury, which is the most common scenario we see. Head injury patient usually having a history of road traffic accident or fall from height. If patient is having a mild injury and there is no loss of consciousness or no vomiting and neurologically patient is intact, this sort of patient can be managed at general practitioner level with NSAIDs, painkiller and close observation. If patient is having loss of consciousness, repeated vomiting, seizure or drowsiness, patient will require further investigation and treatment accordingly. These are the few cases which I mentioned here. This is a 20-year-old male patient with a history of road traffic accident, having a headache and vomiting and conscious oriented obeying with no neurological deficit. If some of you, out of you, if you can diagnose, what do you see in this CT scan? Ma'am? Anyone? So basically this is a plain CT scan. In fact, there is nothing inside the intracranial compartment. Patient is just having the hematoma and the scalp hematoma. We call it as a subgaleal hematoma. So in such cases, patient does not usually require any intervention unless there is a big large CLW which requires suturing. Other than that, only observation, rest, patient will be fine in next 24 to 48 hours. This is the second case. This is a 45-year-old patient which came with a history of fall from height with the complaint of headache and vomiting. There is a history of brief loss of consciousness followed by complete recovery. And after few hours, again patient became unconscious. So initially it is a misleading that patient has lost consciousness and again he has become completely recovered. But now it's a dilemma what to do further. In such case, patient is having a convex lesion in the right frontoparietal region. This is basically nothing but the epidural or extradural hematoma. Extradural hematoma is usually because of the rupture of the middle meningeal artery, which is very notorious, and in a span of maybe in a minutes or an hour, patient bleeding will increase that much that patient will develop massive edema and a midline shift, and patient will cone and patient will die in front of you. This lucid interval was one case, one finding. You see it in extradural and subdural hematoma cases. This is a third case. This is a 30-year-old male patient presented with in unconscious state with the GCS of 4/15 with bilateral dilated pupil. At this state, patient was having extensor posture. There is nothing much we can offer at such with the GCS of 4/15 with the bilateral dilated pupil. Though we operate, there are very less chances that patient may survive with such massive edema and the subdural hematoma on the left side. On the contrary, if you are seeing on the left side, this is a 70-year-old male gentleman who has presented with imbalance while walking, falling towards right side and excessive sleepiness. On examination, patient is having power of 4/5 on the right side along with mild pronator drift present. There was a history of trivial trauma 1 month back. Patient just banged his head on the one of the furniture, and after that patient was absolutely fine. But the only reason patient was on blood thinner and he was elderly. So you can see on that CT scan, both the scans are showing the similar mass effect on right side, but on the left side of the scan, the hematoma which is present, it is a chronic subdural hematoma rather than the one which is on the right. It is a acute subdural hematoma, where the patient is in the left side of the scan. It is a 70-year-old male where there is a brain atrophy. You can see the Selvan fissure is quite open. So there is a edema. There is a space for the edema to expand. There is a space for the brain to expand, and such patient is not in an unconscious state, but patient is conscious oriented. Such patient just require maybe 1 or 2 burhole and evacuation of hematoma. Patient symptom will resolve. Case number 4. This is the 70-year-old male patient with the history of fall from height of 10 feet with the large CLW on the occipital region. So patient has fallen down on the occiput, but patient has developed a large contusion in the bifrontal region which is causing his symptoms. Patient is in an unconscious state with multiple episodes of seizure and vomiting. This patient requires bifrontal craniotomy with opening of the dura. Patient will have a very notorious course of hospitalization. Maybe he'll require admission in ICU. He'll require proper ICU admission for 15-20 days and maybe a month or so in the ward. Followed by that, patient can go home. But all patients would not survive in such cases because of the complication and the comorbidity. On the right side is a 52-year-old gentleman with the known case of hypertension and blood thinner with the history of vomiting, weakness, followed by seizure and loss of consciousness. You can see patient is having right side of frontal region subdural hematoma with ICH. Such patient will just require evacuation of the subdural hematoma along with the, if it is on the right side, it's a non-eloquent area, so hematoma removal can be done without with minimal deficit. This is case number 6. There is a 55-year-old male patient found unconscious in the bathroom in early hours of the day. Patient is having right-sided upper and lower limb weakness with pupil bilaterally equally reacting to light with the GC of 9/15. Patient is having hematoma on the left side of the brain. The left side of the brain controls the right side completely along with the speech and all. So patient was hardly able to speak anything. This patient may just require observation in the ICU with the anti-edema measure like mannitol and 3% normal saline and any other supportive medication. If patient GCS drop less than 8, patient may require intubation and ventilatory support for 48 to 72 hours, followed by intensive care in the ICU and extensive physiotherapy for further management and rehabilitation. On the right side, his patient is a 45-year-old male patient with inability to stand, sudden onset of inability to stand with severe headache and vomiting. Patient's GCS was 13/15 with nystagmus present and pupils were bilaterally equally reacting to light. This patient did just require suboccipital craniotomy and hematoma of evacuation. Though the course of during hospitalization was lengthy, but patient recovered completely and went home after the surgery. Surgical intervention in head injury is based on clinical conditions and GCS at the time of presentation. Time lapsed after the initial insult to the brain, age of the patient, comorbidity, area of the brain which is affected, and ongoing medication like blood thinner like ecosprin, clopidogrel, and any other medication. So neurological intervention in intracranial hemorrhage is justified only when it offers the realistic chance of survival with meaningful neurological function and not mere prolongation of life. Then I come to the topic of normal pressure hydrocephalus. Elderly patient comes with the symptoms of triad of gait disturbance, cognitive decline like short-term memory loss, slow processing, and urinary urgency or incontinence. If you do examination, patient will have a broad-based short-step magnetic gait. On mini-mental score examination, it will be less than 24 out of 30, but there will not be any focal motor or sensory neurological deficit. On MRI, you will find triventricular hydrocephalus with periventricular lucency. You can see the white margin on the occipital region and on the frontal side as well, which is showing the periventricular lucency. Such patient will require MRI to diagnose the case. Along with, to confirm the diagnosis, patient will require lumbar drainage, consecutive lumbar drainage for 1 or 2 occasions to see the improvement, whether after the lumbar drainage, if patient improves, then VP shunt will help him for his symptoms to be resolved. Brain tumors. Symptoms in the brain tumors will be based on the area of where the tumor is present. Clinical features usually we see in brain tumors could be persistent or progressive headache, often worse in the morning hours, nausea and vomiting, seizure, which is new in onset. Patient never had a seizure in the past, but patient had a seizure, focal neurological deficit, weakness, speech or vision change, loss of smell or altered smell, peripheral vision loss, which is we call as a tunnel vision, which we see in pituitary adenoma. On examination, we have to diagnose with the Glasgow Coma Scale, focal deficit present like hemiparesis or cranial nerve involvement, and papilloedema on the fundoscopy. In imaging, CT MRI, there is a space occupying lesion based on the location frontal, temporal, parietal or posterior fossa. These are the few brain tumor cases. On the left upper corner, there is a large tentorial meningioma, which is a benign condition. Usually patient just present with headache, no other symptoms. Patient and these tumors are slowly progressing, and once you do the complete excision, chances of recurrence are very less. On the right upper corner, patient is presented with 45-year-old male patient presented with just a bitemporal hemianopia, means patient is having tunnel vision, patient is unable to see in the periphery of the visual field, and this was just a presentation. On doing the MRI, patient is having cellular supracellular lesion, which is we call it pituitary adenoma. After endoscopic endonasal transvenous excision of the lesion, patient's vision has completely improved. On the right lower corner, patient is having this patient is a 35-year-old patient presented with just a weakness in the left upper limb. That was the only complaint, followed by one episode of seizure at the time of admission. On the MRI, there is a ring enhancing lesion in the right frontal region. This area is a motor cortex area. If you try to remove such tumor, patient will end up having the complete paralysis of the left upper limb. So for this, in fact, after doing the further investigation, it was found out that patient is having a tubercular abscess. So patient was just given at AKT for 18 months, and patient's symptoms have gradually resolved. These are the two malignant brain tumor cases. This is a 45-year-old male patient came with the altered behavior, excessive sleepiness, and generalized tonic-clonic seizure. This patient, on investigation, the area of the involvement is at the internal capsule and thalamus. So doing the surgery, and the lesion is on the left side. Doing the surgery and removing the entire tumor, patient will end up having complete speech disturbance, complete speech loss, along with the weakness on the right side. Or in such cases, patient just require biopsy, and patient was diagnosed. After biopsy, histopathology came, which has come with the diagnosis of non-Hodgkin's lymphoma, and patient end up having methotrexate and rituximab and other chemotherapy agent post surgery. But within 6 to 7 months of treatment, patient could not sustain, and at the end patient expired. This is the case number 2. This is a 55-year-old female patient, came with a history of personality change, heaviness in head and vomiting. You can see the large lesion in the bifrontal region. We call it as a butterfly glioma. This this tumor is quite large. Removing the tumor, patient may not come out of the ventilator post surgery. So just minimal maximum safe resection on the right side of the tumor was done. Histopathological examination report has come as a glioblastoma grade 4. Patient received chemotherapy, but lifespan after diagnosis of glioblastoma is usually 12 to 15 months, with all advanced chemotherapy and maybe repeated surgery as well. Prognostic conclusion on brain tumors. So good prognosis tumor, there are few tumors where the prognosis is good, which are meningiomas, pituitary adenomas, low-grade glioma, which are grade 1 and 2. Prognosis is there in malignant tumor like high-grade glioma, melanomas, metastasis and lymphoma. In malignant brain tumor with advanced treatment option like supratotal excision under navigation guidance, targeted radiation, proton beam radiation, newer chemotherapeutic agent, redo surgery, quality of life can be improved significantly, including overall survival rate. This is one more case of 58-year-old male patient with the progressive weakness of lower limb, band-like sensation with sensory loss below, constipation and urinary continence, anorexia and weight loss, and fever. Patient is having a fracture vertebra at D7, D8 level. On examination, a patient is having Babinski sign positive bilaterally with hyperreflexia in bilateral knee and ankle. Power was 2/5 in lower limb and sensory loss. After doing the MRI, there was a collapsed vertebra with an abscess at dorsal spine. Patient required decompression and fixation with screw and rod, and patient did well after rehabilitation of 1.5 months of physiotherapy. Benign intracranial hypertension, 35-year-old female with obese, come with complaint of severe headache, mostly in morning hours, relieved after vomiting, and there is a blurring of vision or double vision, and temporary vision loss and fatigue. On investigation, if you do MRI showing the empty sella, along with maybe in few cases you find a stenosis in the transverse venous sinus. Such patient on fundoscopy there will be a papilloedema. This sort of patient may require lumboperitoneal shunt for relieving the symptoms. Thank you for listening patiently. Thank you. If you have any question, ready to ask.
Thank you so much, Dr. Parswami Chauhan, for that practical and insightful session on managing common neurological problems in general practice. Let's give him a big round of applause, guys. Now it's time for the last 3 lucky draw winners.
Dr. Wakar Monim.
Congratulations, Doctor.
Dr. Rohit Jadhav.
रोहित जादव
नहीं है अरे
Congratulations.
Vittal sir.
Dr. Suhas Patil.
Congratulations to all three lucky draw winners.
Suhas Jagdale is going to take the bumper prize.
Now requesting Dr. Komal Dumre to felicitate our speaker, Dr. Parth Swami Chauhan. Along with Dr. Abhijit. Thank you so much. With that, we come to the end of our scientific sessions. On behalf of everyone present, I extend heartfelt thanks to all our speakers for sharing their expertise and enriching our knowledge. Thank you so much once again to all our speakers. And now we come to the next part of the session. As we all were waiting for that is bumper prizes. But, before that, let's felicitate all our sponsors for whom these bumper prizes, lucky winners and everything is possible. So let's felicitate our sponsors. We'll start with our major sponsor, MOC, requesting Dr. Abdul Hai Sheikh to felicitate our sponsor, MOC, requesting MOC को felicitate. Next, we have Hiranandani Hospital requesting Dr. Abdul Hai Sheikh and Dr. Anil Dhanaude to felicitate our next sponsor from Hiranandani Hospital. Next, we have Adi Arogyam. Next sponsor, we have Adi Arogyam requesting Dr. Abdul Hai Sheikh and Dr. Manoj Gupta to felicitate our next sponsor. Next, we have HSV Hospital requesting Dr. Abdul Hai Sheikh and Dr. Manoj Gupta to felicitate them. Next, we have HSV Hospital. Next, we have HVS Hospital. Okay. Next, we have HNV Hospital, requesting Dr. Abrar to please felicitate our sponsor. Next, we have Ruby Hospital, requesting Dr. Abhijit Kadam and Dr. Jyoti Bhagat to felicitate. Next, we have Astha Hospital, requesting Dr. Abhijit and Dr. Nilesh Chauhan to felicitate.
Astha, come on stage.
Let's give them a big round of applause. Next, we have Lifestyle, requesting Dr. Abhijit and Dr. Jai Prakash Pol to felicitate. Now we have Nebula Diagnostics Scan Center, requesting Dr. Abrar Inamdar and Dr. Suhas Jagdare to please felicitate.
It is Suhas Jagdare.
Next, we have Dr. Zahir Abbas Merchant, requesting Dr. Abrar Inamdar and Dr. Sachin Pokalwar to felicitate. Next, we have Dr. Vikas Pandey, requesting Dr. Seema Mandaukar and Dr. Suhas Patil to felicitate. Next, we have Pulse Scan Center, requesting Dr. Seema Mandaukar and Dr. Ram Verma to felicitate. Requesting Dr. Seema Mandaukar and Dr. Ram Verma to felicitate. Diagnostic Scan Center, requesting Dr. Umar Syed and Dr. Digambar Patil to felicitate. Next, we have Navkar Hospital, requesting Dr. Umar Syed and Dr. Jatin Kalyani to felicitate. Requesting Dr. Umar Syed to felicitate. Let's give them a big round of applause. Next, we have Malvankar Hospital requesting Dr. Prashant Shinde and Dr. Bhushan Rokhare to felicitate. Requesting Dr. Prashant Shinde and Dr. Bhushan Rokhare to felicitate. Next, we have RBM Diagnostic Lab requesting Dr. Prashant Shinde and Dr. Sunny Vaikode to felicitate. Next, we have Gogri Path Lab requesting Dr. Abdul Sheikh. No. Next, we have Trishala Diagnostic Lab requesting Dr. Abdul Hai Sheikh and Dr. Sanchi Ram to felicitate. Next we have Sai Care Hospital requesting Dr. Prashant Shinde to felicitate. Now we have Pulse Scan Center requesting Dr. Seema Mandavkar and Dr. Ram Verma to felicitate. Dr. Seema Mandavkar and Dr. Sachi to felicitate.
Sachi ma'am, come fast. Wait.
Thank you so much. Now I request Vice President of VKPGP Association, Dr. Abrar Inamdar, to say a few words. Let's give a big round of applause for our Vice President.
गुड इवनिंग, शुभ संध्याकाळ. मुझे पता है आप लोग मुझे सुनने के लिए नहीं बैठे हैं, बम्पर के लिए बैठे हैं. मेरा चलो मौका अच्छा है, मार लेते चौका है. ओके, थैंक यू. फर्स्ट थैंक्स बोलूँगा अपने वीकेपी जीपी एसोसिएशन के प्रेसिडेंट, द चार्म ऑफ विक्रोली, हैंडसम पर्सनैलिटी, टैलेंटेड गाय, डॉक्टर अब्दुल हाई शेख सर. Next, again, Dr. Abhijit Kadam sir. Next, Dr. Umar Sayyed sir. आणि आपले Dr. Prashant Shinde sir. Seema ma'am, Sachi ma'am, Shobha ma'am, all VKPGP विक्रोली कांजुरमार्ग पवई जनरल प्रैक्टिशनर एसोसिएशन के जितने भी अपने मेंबर्स और यहाँ पर जितने भी सब पूरे जितने सीनियर प्रैक्टिशनर, मेरे कलीग, जूनियर्स, सबका मैं आपको धन्यवाद करता हूँ कि आप लोग यहाँ आए, सुबह से यहाँ पर बैठे, डट कर बैठे, अभी भी बैठे हैं बम्पर प्राइस के चक्कर में. ओके, now आज जरा मराठीतून बोलतो, मराठीतून मला जरा कम्फर्टेबल होतं बोलताना, चालेल. आज आपण पूर्ण 1 वर्ष पूर्ण केलं. मागची आपली जी ॲन्युअल फंक्शन होतं त्याच्यानंतर हा सेकंड ॲन्युअल फंक्शन आहे. वी कम्प्लिटेड अ सक्सेसफुल 1 year ऑफ VKPGP. आणि ह्या प्रवासामध्ये हा दुसरा आपला प्रोग्राम आहे. एका वर्षामध्ये हा दुसरा आपला आहे जो ॲन्युअल कॉन्फरन्स आपल्या सबर्बमध्ये सगळ्यात बेस्ट, सगळ्यात टॉप 1 नंबरवरती आज झालेली आहे. हा क्राऊडच इथं जमलेला सांगतो
की हा VKP GPची युनिटी कशा प्रकारे आहे. सगळ्यांना माहीत आहे, थोडं असोसिएशनबद्दल बोलणार आहे, कारण की ह्या असोसिएशनने आपल्याला जवळ आणलं. आणि असोसिएशन का गरजेची आहे, कशासाठी लागतं. मी काम केलं, भरपूर संघटनेच्या बरोबर काम केलेलं आहे, भरपूर लोकांना पण माहिती आहे. परंतु आपल्या विक्रोळीच्या ह्या कांजूर पवईच्या एरियामध्ये आपल्याला जनरल प्रॅक्टिशनर असोसिएशनची का गरज होती, कशासाठी गरज होती. आपण अनुभवलं भरपूर वेळेस की जेव्हा आपण एखाद्या कोणत्या गोष्टीचा प्रॉब्लेम येतो किंवा एखाद्या गोष्टीबद्दल कोणतं बोलायचं असतं. आता मी आज 2-3 जणांना ऐकलं, MPCPBचे आले होते आणि त्यांनी ते पोल्युशन बोर्डचं सर्टिफिकेट मागत होते एकट्याला. परंतु हा जर एकट्याच्या आवाजा ठिकाणी तो एक GP घाबरला होता. आणि जर समजा त्याच ठिकाणी त्या 100 GP जर जाऊन बोलले तर तो घाबरेल. म्हणजे एकीनं व्यवस्था तुम्हाला मारेल आणि एकट्याने व्यवस्था तुम्हाला मारेल जर तुम्ही एकटा असाल, आणि एकीने तुम्ही व्यवस्थेला घडवाल, व्यवस्थेला बदलाल तुम्ही. ह्याचा आपण दरवेळेस अनुभव घेतला. मागच्या वेळेस आपण आपला SMS बद्दल आपल्या असोसिएशनने जाऊन ह्या गोष्टीबद्दल केलं. त्याच्यानंतर महानगरपालिका, आपल्या नगरपालिका यशवाडमध्ये पण आपण गेलो, एकीचा इफेक्ट भेटला. त्याच्यानंतर अजून एक 2-3 घटना घडले, त्या घटनामध्ये पण आपल्याला एकीचं आपल्याला ह्या गोष्टी दिसल्या. दुसरी गोष्ट, आपण जनरल प्रॅक्टिशनर आहोत. प्रॅक्टिस करण्यासाठी डिग्री लागतं, बरोबर आहे. डिग्री आहे, तुम्ही प्रॅक्टिस करू शकता. परंतु एखादा समाज घडवण्यासाठी किंवा एखादा त्या लोकांमधला विचार बदलण्यासाठी तुमची एक संघटना असं गरजेचं आहे, आणि ती संघटना तुम्हाला मार्ग दाखवणारी असायला पाहिजे. आणि VKP GP असोसिएशन डॉक्टर अब्दुल हई शेख यांच्या नेतृत्वात बोलू आपण किंवा त्यांच्या विजनने आपण आज सगळे एक बॉन्डिंग तयार झालेली आहे, सगळ्यांची एक बॉन्डिंग झालेली आहे. आणि मला असं वाटतं की ही बॉन्डिंग वर्षानुवर्ष राहणार आहे. थोडंसं अजून 2 गोष्टी अजून बोलू इच्छितो. आपण बघितलं सगळेजण, आता ह्या कॉर्पोरेट सेक्टर आहे, सगळे इथं सगळ्या लोकांचे हॉस्पिटल आहेत, काही जणांचे जे आता स्पॉन्सर केलेले आहेत, असं नाही बोलायला पाहिजे मला. परंतु सर तुम्ही डिसीज क्युअर करता, आम्ही समाज क्युअर करतो. कारण की जनरल प्रॅक्टिशनर हा समाजामध्ये जो घर राहतो. बघा ना तुम्ही, पावसाळ्याचे दिवस असू द्या किंवा काही असू द्या, साथीचा आजार असला का सर्वात आपल्या अगोदर कुणाला फोन येतो. रात्री फोन जर समजा एखाद्याच्या घरात ताप आला मुलाला, सगळ्यात अगोदर फोन कुणाला जातो. मग त्या झोपडपट्टीपासून असू द्या का तो 45 माळ्याचा टावर असू द्या, तिथपर्यंत पहिला फोन कुणाला येतो. रात्रीचे 2 वाजू द्या, रात्रीचे 3 वाजू द्या, कुणाला येतो, जनरल प्रॅक्टिशनरला येतो. म्हणजे पहिली आरोग्य व्यवस्था सांभाळणारे कोण, म्हणजे तुम्ही आणि आम्ही, जनरल प्रॅक्टिशनर. त्याच्यामुळे आपली एकी खूप काय घडवू शकतं. दुसरी गोष्ट, असोसिएशनची अजून काय गरज आहे आपल्याला. ते पण सांगणार आहे सर, त्याचं पण पुढे आहे, तुम्हाला टेन्शन नका. भावनिक आणि सामाजिक अधिकार, भावनिक आणि सामाजिक आधार. आपण पण मनुष्य प्राणी हो, आपण 24 तास काम करतो. सकाळी उठतो, OPDमध्ये जाऊन बसतो, परत दुपारी जातो, जेवतो, संध्याकाळी उठतो, परत आपण OPDमध्ये जाऊन बसतो. नॉर्मली पीपल सकाळी 9 ते 5 काम करतात, घरी येतात, लेकरं बाळासोबत जे काही त्यांना कुठं जायचं असेल बाहेरचं एन्जॉयमेंट करतात आणि एन्जॉयमेंट करून येतात. पण आपण आपल्या टायमाला त्यावेळेस आपण क्लिनिकमध्ये असतो. मग या भावनेला कोणीतरी समजून घेणारा, या भावनेला कोणी कदर करणारा आणि त्याच्या आतला जो मनातली खदखद आहे तो व्यक्त करणारी जागा म्हणजे कोणती आहे, तर ती आहे असोसिएशन. ह्या एकसाठी गरज आहे. तिसरी गोष्ट सरांनी बोलले, आता CMEच्या नावाखाली पार्टी करायला. तिसरी गोष्ट अजून आहे, थोडक्यात सांगितलं गेलं तर आपण अजून एक महत्त्वाची गोष्ट सांगतो. आपण जनरल प्रॅक्टिसच्या थ्रू समाजामध्ये विश्वास कमावण्याची खूप गरज आहे. आज थोडं जनरल प्रॅक्टिसमुळे आपला जो समाजाचा विश्वास आहे आपल्याकडून नाहीसा होत चालला. आपल्या सिनियर लोकांचा जेवढा विश्वास होता, आज पण आपण बघितलं तर आपण भरपूर वेळेस चुकून होतो. सुहास म्हणतो, सर माझ्याकडला पेशंट तिकडे सिनियर डॉक्टरकडे गेला. अरे का गेला? तू कसं वागितला? हा तू बघितलाच नाही. हा सुहासचाच एकटाचा नाही, नाहीतर मी सुहासला एकदा पण दिलं म्हणून नको, भूषण तू पण. ओके, तर आपण आदर्श निर्माण करायला पाहिजे. अशा प्रकारे आपण वागायला पाहिजे की त्याला असं वाटायला पाहिजे की खरंच हा व्यक्ती माझ्या घराबद्दल माझ्याबद्दल विचार करतो, आणि त्याला असं वाटायला पाहिजे की आपण हा माझा घरचा माणूस आहे. आणि जेव्हा पण तुम्ही पेशंटच्याबद्दल विचार कराल त्यावेळेस स्वतःच्या घरचा विचार करून त्या हिशोबाने तुम्ही त्याला कराल. ओके, आणि आणि एवढी असायला पाहिजे. एक सांगतो, ज्युनियर जेवढे आलेत त्यांना एक सांगतो, पेशंटच्या नजरेत नजर टाकून बोलण्याची ताकद असायला पाहिजे, अशी प्रॅक्टिस करायला पाहिजे. नेक्स्ट, चालेल, तसं भरपूर आहे, परंतु मला माहिती आहे तुम्हाला लोकांना आहे की नाही, बंपरच पाहिजे. आणि बंपरच्या नादामध्ये इनामदार किती बसतो का भरोसाच नाही म्हणे ह्याचा. ह्याला काय वाटतं म्हणे आंदोलन करतो आणि भाषण देतो येतोय. ओके, ठीक आहे. आपल्या असोसिएशनचं उद्दिष्ट सांगतो पुढे आपल्याला, एकत्र शिकूया. ज्या काय गोष्टी असतात, आपण जेव्हा CMS करतो तर CMS फक्त खाण्यासाठी किंवा पार्टी करण्यासाठी येत नाही, तर त्या ठिकाणी आपण जेव्हा एकत्र येतो, वेगळ्या वेगापातून येतात. कोणी पवईवरून येतं, कोणी कांजूरमधून येतं, कोणी भांडूपवरून येतं, कोणी टागोरनगर, कोणी कन्नमनगर, आणि तिकडल्या त्या पेशंटचा एक्सपिरियन्स जो त्याला आलेला असतो तो शेअर करतो. अशा प्रकारे आपल्याला एकमेकाकडून ज्ञानाची आपण काय म्हणतो देवाणघेवाण होतं, त्याच्यातून आपल्याला भरपूर शिकायला भेटतं. सिनियर लोकांकडून आम्हाला ज्युनियरला शिकायला भेटतं, आमच्याकडून अजून दुसऱ्या कुणाला शिकायला भेटेल. ही सायकल चालते, म्हणजे ज्ञानाची भर वाढेल. त्या हिशोबाने आपण पुढे CMS कंटिन्यू करूया. कोणत्याही परिस्थितीमध्ये आपण एकत्र उभे राहूया, एकत्र सेवा करूया. आणि लास्ट बट नॉट लिस्ट, आज जेवढे आपल्या सिनियर प्रॅक्टिशनरना आपण लाईफटाईम अचीवमेंटना त्यांना दिलेले आहेत, त्यांनी सर्वांनी आपल्यासमोर आदर्श ठेवलेले आहेत. माझ्यासमोर आदर्श मी बघत आलेलो मागच्या 13 ते 15 वर्षामध्ये डॉक्टर धारोड सर इथे आहेत. त्यांना बघून खूप काही शिकलेलो आहेत. तो व्यक्ती त्यांनी कसे आहेत हे पर्सनली मला माहिती आहे. पर्सनली मला माहीत, कुठं त्यांनी मदत केली, बंद मुठ्ठीनं मदत केली, कशी केली, ह्याचा अनुभव मला आहे. असाच सर तुमचा हा आदर्श मी सदैव माझ्याकडे ठेवेन, आणि तो पण मी माझ्याकडून दुसऱ्याकडे पास करण्याचा प्रयत्न करेन. हे तुमच्याकडून आम्हाला शिकायला भेटलं, त्याच्याबद्दल खूप खूप धन्यवाद. सगळ्या सिनियर प्रॅक्टिशनर्सचा, रवींद्र सराफ सर, नेर्लेकर सर इथं आहेत, दळवी सर आहेत, कोळगे सर आहेत, मोरे सर नहीं आहेत आज. अच्छा गांधी सर, आपको भी सीनियर बना दूं? नहीं, मुंडी उठा के देख रहे हैं आप, तो बोला ठीक है, चलो थैंक यू. ओके, अनिल धनावड़े सर उधर से हाथ बताए. सर सीनियर है आप सर, मान लो ये बात को. सर SM जैन सर, तो सर वो तो मैं बोलूँगा विक्रोली घाट के ऊपर अपना जो सबर्ब का जो एरिया है उनके लिए, वो सबके लिए अपने लिए एक आदर्श है SM जैन सर. और सर, और लिटरली मैं इस बात मला असं सर खूप ह्या एजमध्ये पण तुम्ही येता, आणि सर्वात महत्त्वाची गोष्ट सर कोणत्याच CMEमध्ये आणि ॲन्युअल फंक्शनमध्ये जात नाहीत. आणि सर आज आपल्या इथल्या विक्रोळी GPच्या फंक्शनमध्ये इथं सकाळपासून आहेत आणि आत्तापर्यंत बसल्यात. सर खूप खूप आभार सर तुमचे. सर प्लीज कम ऑन डायस सर. हाँ, आम्ही आता उद्दिष्ट में बताऊंगा मैं सर, रुको ना. उद्दिष्ट में
He is the guy who stand 12 to 16 hours in his clinic. He don't sit. He don't sit. मैं उनको 20 साल से खुद जाके मिलता हूँ तो. He never sit. He keep standing.
लो आदर्श, कल से खड़े हो जाओ तुम, अभी बैठो मत करो. थँक यू व्हेरी मच सर. सरांचं एक स्वप्न आहे, SM सरांनी बोलून दाखवलेलं आहे की आपल्या विक्रोळी GP असोसिएशनची स्वतःची जागा असायला पाहिजे, स्वतःचं ऑफिस असायला पाहिजे. सर नक्कीच येणाऱ्या काही दिवसामध्ये हा तुमचा स्वप्न आम्ही नक्की पूर्ण करण्याचा प्रयत्न करू. थँक्यू सर. आज सगळ्यांना पुरस्कार भेटलेल्या आणि सगळ्यांना लकी ड्रॉमध्ये गिफ्ट लागलेल्यांना आणि ज्यांना नाही लागलं त्यांना पण सगळ्यांना पुढच्या वर्षी तुम्ही या, तुम्ही त्याच्यानंतर त्याच्यामध्ये परत ट्राय करा. यशी शुभेच्छा देतो. आणि विक्रोळी GP असोसिएशनचं ॲज अ व्हाईस प्रेसिडेंट कमी आणि तुमचा मित्र म्हणून जास्त तुमच्यासोबत राहण्याचा मला योग लाभत राहो हीच माझी काय बनेल अपेक्षा बनेल. आणि पुढच्या आपल्या GP असोसिएशनच्या पुढच्या वाटचालीस खूप खूप शुभेच्छा. दुसऱ्या शब्दात बोलेल तर विक्रोळी GP असोसिएशन चिरायू हो. जय हिंद, जय महाराष्ट्र. थँक्यू.
Now we have few more sponsors to be felicitated. Firstly, we have Kethi Kids Pharma requesting Dr. Prashant and Dr. Bhushan to felicitate. Next we have Sai Angel Hospital requesting Dr. Prashant and Dr. Bhushan to felicitate. Sai Angel Hospital. Let's give a big round. Next we have Criticare Asia requesting Dr. Sanchi and Dr. Parth to felicitate. Requesting Dr. Sanchi and Dr. Parth to felicitate to Criticare Asia. Let's give them a big round of applause.
माजी सर बम्पर में खुद को ढूंढ रहे हैं.
Hello. Thank you everyone for having Criticare Asia group of hospitals here. We won't be taking much of your time, but just a small highlight. We are the only institute which is a DNB registered institute. So the future is lying with Criticare Asia group of hospitals. We have 2 seats of anesthesia, 2 seats of MD medicine and 2 seats for ENT. So the infrastructure is completely backed up as a one-stop solution. And Inamdar sir ने कहा कि झोपड़पट्टी से लेके 45 फ्लोर का बिल्डिंग तक each and every strata of the society's patient can be treated at Criticare. We have one of our consultants sitting here. You can ask, Dalvi sir has also been one of the prime supporters. Abdul sir has also experienced couple of relationships with us. We are a transparent group of hospitals, everything under one roof, and the future is the science. We are completely backed up with the technology. We are the only group of hospitals in the city who has 3 joint replacement robos. So It's just not the technology, but it is affordable at Criticare Asia Group of Hospitals. जैसे आपने कहा कि family physician is the important. The key of Criticare started in 1999 at Juhu with 16 beds, entirely supported by a family physician, having one corporate hospital on the left, which is Kokilavin, and one is Nanavati. We are still making our own way. We are progressing, and the journey has been very successful because of a principle that by the doctor, for the doctor. So family physicians are welcome for any suggestions, decisions, what you require to take. Affordability is not a criteria. The criteria is to treat the patients, and we are here to support you. Thank you very much.
Thank you so much. Now we have KT Kids Pharma requesting Dr. Shobha and Dr. Abdul Hai to please felicitate. Now we have KT Kids Pharma. Let's give them a big round of applause. A heartfelt thank you to our valued sponsors for your generous support and belief in our vision. Your contribution has played a vital role in making this event possible and successful. Once again, a very big round of applause for all our sponsors. And now we have our president, Dr. Abdul Hai Sheikh, to speak a few words. I know you all are tired.
Hello. Okay, only few words. I had a lot of papers, I guess. Sir, paper do do. So, this is my speech for today. So, 2 pages speech. But I am very glad कि मेरा बहुत सारा काम मेरे वाइस प्रेसिडेंट ने और मेरे सेक्रेटरी ने कर दिया. तो मैं दिल से बहुत बहुत शुक्रिया बोलना चाहता हूँ. मनापासून आभार साहेबांचा. दूसरे साहब किधर गए? सेक्रेटरी साहब ठीक है. एनीवेज उसको शाम को चाय कॉफ़ी लगती रहती है. ठीक है. आपके सामने खड़ा हूँ. सबसे पहले तो आप सबका बहुत बहुत शुक्रिया. तहे दिल से आप सबका शुक्रिया. इतनी इज्जत बख्शी और हमको इतना प्यार दिया, इतना सराहा आप सब ने. हमने दिलो जान से इस प्रोग्राम के लिए मेहनत की. हर प्रोग्राम के लिए करते हैं, इस प्रोग्राम के लिए सबसे ज़्यादा की. और उसका रिजल्ट जो है ये आप लोग जो यहाँ पे बैठे सुबह से लेके शाम तक का. सो दैट इज़ आवर गेन. दैट इज़ द हॉस्पिटैलिटी व्हाट वी एज अ विक्रोली जीपी एसोसिएशन हैज़ बीन ऑलवेज डूइंग फ्रॉम डे 1. कविता मैम, यू ओके? या शी इज़ ओके. थैंक यू मैम. एंड मैनी पीपल यहाँ पे बहुत सारे लोग हैं. मैं हिंदी में भी बोलूँगा, मराठी में बोलूँगा, इंग्लिश में भी बोलूँगा, सबको समझ में आ जाए. और वेरी शॉर्टली क्विकली इसको ख़त्म करते हैं, फिर आपके बम्पर प्राइस पे जाते हैं. उसमें मैं भी मेंबर हूँ. मुझे भी बम्पर लगा तो किसी ने उंगली नहीं उठाना, इसको कैसे लग गया. तो कोशिश यही है कि मुझे ना लगे. बट वेरी फ्रेंकली टू टेल यू, ऑल माई सीनियर्स हियर, हमने जिनको आज फेलिसिटेट किया. जैन सर सुबह से आए. थैंक यू वेरी मच सर फॉर कमिंग. एंड मेरी फीमेल्स डॉक्टर्स, आप कोई एसोसिएशन में जाओ और मुझे बता दो यहाँ पे इतनी फीमेल्स है. जीपी एसोसिएशन में हमारे पास फीमेल्स की लाइन लगी है. एंड आई एम वेरी प्राउड टू से दैट बीइंग अ प्रेसिडेंट ऑफ द एसोसिएशन, 30% ऑफ द फीमेल्स हैव ऑक्यूपाइड द सीट. सो आई वांट दिस टू बी 50%. सो मोस्ट प्रोबेबली बाय कमिंग नेक्स्ट 2027 सेमिनार में हम 50% फीमेल और 50% मेल में बैठेंगे. तो मेरी यही उम्मीद है आप सबसे. आप इसी तरह जुड़े रहिए हम सब के साथ. हमको इसी तरह प्यार दीजिए, सराहिए. हमसे कुछ गलती हुई तो माफ़ी चाहते हैं, बट उस गलती को सुधारने का मौका दीजिए. किसी में, मैं आपको एक बात बता दूं, आज तक ना मैंने कभी सुना ना आपने कभी सुना होगा, किसी ने भी इतनी हिम्मत करके ये नहीं बोला कि भाई मुझसे गलती हुई है, मैं माफ़ी चाहता हूँ, कुछ चीज़ें हमसे रह गई है, जो मेरे वाइस प्रेसिडेंट ने आज किया. और मैं उनको चिल्ला रहा था कि आपने ये क्यों बोला. तो बोले मुझे बिल्कुल अच्छा नहीं लगा कि हम इतनी मेहनत करने के बाद ये छोटी सी चीज़ हमसे रह गई. और हम उसको मुकम्मल तरीके से पूरा कंप्लीट नहीं कर पाए. And I'm very proud. I have a team of vice president, secretary, everyone from head to toe, from my 3 ladies, from my all the team works, my 3 musketeers, whatever I will call them, Parth, Bhushan, Sunny, the 3 S we call them, Sachi Ram, Seema Mandaukar, and Shobha Singh. Shobha ma'am is here. And the committee members from Yogesh Bhalerao, Ajit Morankar, Majid sir, myself as a president. अब मैं क्या बताऊं हमारी खूबियां, आप लोग तो अभी सब जानते ही है, सब हम लोग अच्छे ही कर रहे हैं, टकाटक है हम लोग, और इसी तरह प्रोग्रेस करते रहेंगे. आप सबसे यही उम्मीद है, इसी तरह प्यार देते रहिए, आते रहिए प्रोग्राम्स में, हमको और बेहतर करने की उम्मीद है आप लोगों के लिए. बहुत सारे प्रोग्राम्स है लाइंड अप, और उसमें सबसे ज़्यादा इंपॉर्टेंट है, जैसा अबरार सर ने बताया, कि जगह, एसोसिएशन के लिए एक जगह, हम उसके पीछे मेहनत कर रहे हैं. बहुत जल्दी एक जगह होगी, पर उसके लिए मुझे आप लोगों का सपोर्ट चाहिए. फाइनेंशियली बहुत ज़्यादा, इमोशनली आप लोग हैं, फिजिकली भी आप लोग हैं, पर मुझे फाइनेंशियली लगेंगे. जो फैक्ट है मैं बता रहा हूँ, बिकॉज अगर एसोसिएशन का छत नहीं है तो उसकी कोई वैल्यू नहीं है. सर बम्पर दे के डंपर ले रहा हूं. फक्त एवढं सांगायचं सगळ्यांना, प्लीज कम फॉरवर्ड फॉर द हाउस ऑफ दिस एसोसिएशन. घर आप लोगों के बिना अधूरा है, और हम भी आप लोगों के बिना अधूरे हैं. हम सब एक फैमिली है. हम एक दूसरे से लड़ेंगे, झगड़ेंगे, मिलेंगे इसी प्लेटफॉर्म पे. एंड आई एम लिटिल इमोशनल टुडे, बिकॉज दिस इज द प्लेटफॉर्म. मैंने यहीं से अपनी शुरुआत 1 साल पहले की थी. आज ये 2nd ईयर है, मेरे साथ सब खड़े हैं, और इसी उम्मीद के साथ ये लोग मेरे साथ खड़े हैं, और मैं आपके साथ खड़ा हूं कि कुछ बेहतर आपके लिए कर जाऊं. जब तक मेरा टेन्योर है, मैं यही दुआ करता हूं ऊपर वाले से कि कोशिश यही रहेगी कि आपको कभी नाराज ना करूं. इसी से मैं अपना स्पीच खत्म करता हूं. 2 पेज का था, एक रह गया. थैंक यू वेरी मच, थैंक यू वेरी मच, थैंक यू वेरी मच.
Thank you so much, Dr. Abdul Hai Sheikh. Now,
वेट. कोई बात नहीं अब्दुल भाई, आपके 2 पेज प्रिंट करवा के अपन पीआरओ के थ्रू सबके क्लिनिक पे पहुंचा देंगे.
So, okay, now no ifs, no buts. Now only bumper. So, are you guys ready?
मैं
विठल सर ने जैसा बोला, बम्पर दे के डंपर ले रहे हैं हम लोग, तो डबल बम्पर लेंगे. तो पहले तो निकाल लेते बम्पर किसको मिलता है, देखते. चलो,
बम्पर दे रहे हो, ले रहे हो. सर आज तक वीकेपी जीपी जब से फॉर्म हुआ है, मुझे आप लोग बताओ, वीकेपी ने लिया है क्या दिया है?
भर भर के दिया है भाई, सिर्फ दिया नहीं है, भर भर के दिया है.
तो डोंट वरी,
विठल सर,
वीकेपी जीपी देकर ही जाएगी.
मैम सेट
मैम
1-1.
अच्छा, थोड़ा टाइम लेना है क्या फिनिश करना है? टाइम लेना है थोड़ा.
नहीं 6:30 हो गया. तेरा कौन सा है? 1 मिनट, तेरा 2 लाख.
फर्स्ट बम्पर नहीं, बोल दो पहले. फर्स्ट बम्पर क्या है?
एयर फ्रायर.
एयर फ्रायर,
यस.
किधर है एयर फ्रायर?
काय आहे डबल पी है नहीं है पी पी
पी. क्या बात है, पी पी
पाटिल
पी.
उसको बोलता है बम्पर से ज्यादा मेरे घर पे जो बड़े वाले वो बहुत ज्यादा डंपर है. नकू बोले. नेक्स्ट सविता भालेराव. बैड लगू.
क्या हुआ?
नहीं बोलूंगा, मेरा नाम आया है.
अरे वाह. For my public. It is for my public.
डॉक्टर अजय जायसवाल.
अरे जागो जागो मोहन प्यारे, जागो, मैं हूँ यहीं पे.
सर इसको कहते हैं सर दोस्ताना, इसको कहते हैं. उन्होंने साबित किया कि एयर फ्रायर की ज्यादा जरूरत आपको है.
भाई लेके जाने की जिम्मेदारी आपकी है, हमारी नहीं है. तो आप अपना ओला उबेर जो भी है बंदोबस्त कर लो. साउंड सिस्टम.
नेक्स्ट साउंड सिस्टम. किसको आवाज सुनना है? डॉक्टर एस एम जैन सर, प्लीज.
डॉक्टर एस एम जैन सर.
आस्था आस्था. Okay, now.
I'm very happy that this bumper prize has been gone to the proper person. He's the best supporter from day one. We have started the hospital in Vikhroli.
Great.
Thank you so much.
And I haven't supported Astha till date, और मुझे लग गया था. So this is the bond between Astha and Abdul Hai.
पहला एयर फ्रायर एकदम सही पर्सन के पास जाके पहुंचा. सच्ची में जरूरत थी उनको एयर फ्राई, ऑयल फ्राई की जगह पे एयर फ्राई खा देंगे. ओके, चलो अभी नेक्स्ट सेकंड एयर फ्राई किसको जाता है देखते हैं.
ये इनामदार सर कौन है यहाँ पे?
Pass it. No, I also pass it. नहीं ऐसा नहीं है, सच्ची में ऐसा तो लोगों को लगेगा छूट लगेगा. फाड़ दिया. अरे छूट क्यों लगे? वीरेंद्र उपाध्याय not available. Cut. डॉक्टर हेमंत जाधव.
हेमंत जाधव सर के बारे में एक दो बात बोलूँगा. ये आफ्टर एवरी CME और एवरी प्रोग्राम ही ट्राइज टू मैनेज आते हैं और आने के बाद एक ही बोलते हैं, सर आप बहुत अच्छा कर रहे हो, आप चलो मैं आपके पीछे हूँ. तो मैं हमेशा बोलता हूँ, सर कभी आप मेरे आगे भी बढ़ो, मेरे साथ में भी चलो, हमेशा पीछे रह के क्या करोगे. He keeps on calling me and telling me that today's function was good and everything. So genuinely बहुत सारे लोग हैं जो अच्छे compliments देते, तो he is one of them.
कितने हो गए गिफ्ट बम्पर? 1 2 3 9 4. क्या तू निकालता? अच्छा निकाल. एक मिनट.
बस हो गया सर, चलो ना 6:30.
Rupesh.
Dr. Rupesh Mandavkar. Sir is there.
Sir
Madam
is
is there, but sir is not there. Sir
bad.
किधर है?
Very bad luck, madam. नहीं तो अच्छा गाना सुनते थे तुम उधर जाके घर पे.
No, H.G.
Dr.
Patil.
H.G. Patil.
No, he is also not there. ए भाई શું ખાધું આજ શું ખાધું ઊંધિયો ઢોકલો જલેબી પાપડા આજા ડોક્ટર કિંજલ ગાંધી.
अब क्या है? अब है आवाज के साथ देखने का मजा. एलईडी टीवी काय पाहिजे? बरं, रवी भाऊचा हक्क बनतोय आपल्यावरती, खरंच बनतो. या रवी भाऊ, कम.
Hello everyone. Hello everyone. I'm Dr. Shashank Sharma. I'm very glad that I have been invited on this stage. I'm very thankful to Namdar sir, the committee members and all our favorite Abdul Sheikh sir. He did a very commendable job to invite you all, where we shared all the knowledge, insight, and I personally met with all the first line healthcare warriors. Now, I am attached to Asta Hospital. We at Asta Hospital are doing all the surgery regarding the urology. If your patients are having a stone, just tension give naka, just refer to us. We are managing from stones to prostate to all the urethras. And to all of you, you are really you are doing a commendable job. Thanks a lot. And the most promising and the event for this day, now I would like to invite Dr. I think she's not here. So I will just Dr. Swati Dabarase ma'am.
आ रहा है धीरे धीरे आ रहा है भाई. धड़कने तेज हो रही है सबकी, 2 ही बचे हैं. एक नंबर किसका है 1 नंबर? विठल सर, यार ऐसा टेम्प्ट मत करो सबके सामने लेकर आके.
अगर धड़कनें तेज हो रही हैं तो मत करिए, क्योंकि आई एम नॉट अ कार्डियोलॉजिस्ट, आई एम अ यूरोलॉजिस्ट. आई विल नॉट बी एबल टू मैनेज. ओके. And name is Dr. H.A.D.I.A. Hadia Khan ma'am.
Ooh. So Dr. Hadia is.
She is a RMO at.
She is basically an RMO working in Ruby Hospital, registered for today's program, sitting since morning till evening and getting back the LED TV. देखो दिखाओ मजा करो. चलो.
विठल सर हमारे आरएमओ को ब्राइब दे रहे हैं.
Okay, the next
ये
and last.
सही ऐसा लग रहा है कि रिश्वत दी है, हाँ? आस्था ने कुछ तो गड़बड़ किया है.
Okay, the last gift of this evening.
जादू का पिटारा है इसके अंदर.
It is a party music box with karaoke mic system. मैं लेकर आया हूँ. बहुत दिल पे पत्थर लिख के लाया हूँ. जितने भी गिफ्ट गए ना, सब ऐसा दिल में पत्थर रख के रखा हुआ. दे दे यार, जाने दे. चलो.
रुको. मैं बोलूँगा. बहुत लकी बंदे हैं. बहुत मतलब. डॉक्टर सिंह कौन है? कौन है? किधर है? प्रतीक सिंह किधर है?
एक एक करके खड़े हो जाओ. सिंह साहब खड़े हो जाइए.
अरे सर किधर? सर एक इसके चक्कर में तुम सिंह बन गए.
सर मोमिन से सिंह कब से हो गए सर? वकार सर ये तो चीटिंग है यार.
नितिन भाई बैठ जाओ. बैठ जाओ. ये सिंह जो है ना वो हमारे दोस्त है. आप मेरे दोस्त हो तो आ जाओ. वेलकम
सर.
डॉक्टर नितिन सिंह इज द लकी गाय.
सर सबके दांत ठीक करते. सर अरे
ये डेंटिस्ट लोग कुछ तो गड़बड़ करते हैं ऐसा लग रहा है मेरे को. लास्ट टाइम का पूरा बड़ा प्राइस जो है वो पीयूष बोकारिया सर लेके गए थे और दिस टाइम का जो है नितिन
अच्छा
सर
एक बात बताओ दो. डॉक्टर साहब जो है ना दांतों के डॉक्टर है. दांत सबके ठीक कर दे. अब ये म्यूजिक सिस्टम घर में लगाएंगे दूसरों के कान फटेंगे. तो थोड़े सी फ्री डेंटल चेकअप फॉर ऑल फ्रॉम डॉक्टर नितिन सिंह आफ्टर विनिंग दिस अवार्ड.
Congratulations to all the bumper prize winners.
Okay, all the delegates gifts are ready outside. Delegate gifts are ready. आप कूपन दे के delegate gifts आप ले लीजिए. Okay, thank you. Coupon is important. Without coupon, no one will get a delegate gifts.
Thank you so much everyone.
अच्छा
for your
one more thing. Last. ये प्रोग्राम को पूरा सक्सेस कराने में सिर्फ हमारी टीम या हमारा हाथ नहीं है. इसमें 2-3 लोगों का हाथ है. तो मैं उनका नाम लूंगा. सबसे पहले हमारे PROs मिस्टर राजन पोरे सर. सेकेंड हमारा दोस्त रवि. और फिर सैम्यूअल. ये तीनों है. और ये साई केयर वाला तो है ही दीपक. बट एनीवेज थैंक यू. और बाकी हम लोग इनका फेलिसिटेशन कर देंगे. चलेगा. थैंक यू.
Thank you so much everyone. With this your host Clarina Gomes signing off for the day. I hope you all enjoyed today's day.
And subcommittee and committee members don't go. We'll have a photograph session.
Thank you
Okay?
once again. Have a great evening.
And Clarina, thank you very much. We are very obliged by your presence. Please come here. So, Clarina, thank you very much. From since morning you're here and standing, and you have done a fabulous job today. Hope so. We see you soon again.
कमिटी सब कमिटी ग्रुप इथंच थांबायचं आहे. वी वांट टू वन ग्रुप फोटो लेने का अपने को. वास्तु उधर करवाया था. तुम लोगों ने वास्तु नहीं किया. प्रशांत सर ने ऑफर भी दिया था तुमको. अरे प्रशांत सर ने ऑफर दिया था पूजा करने का शाम का तुमको. तुम लोगों ने किया ही नहीं.
आपसे पार्टी चाहिए. गिफ्ट गया चलो. आज शाम को सर से पार्टी. नहीं बस एंजॉय.